intelligence is a big umbrella. We have machine learning and deep learning. I'll just tell you what is machine learning and deep learning. So machine learning is a subset which enables to understand from the data. This is something like the Google map which I discussed. Like for example, there is a wrong U-turn, it will remember, it will memorize, subsequent ones it will change it. So that is what a machine learning is probably about. Again, different types of machine learnings are there. I will not go into the details, but just for a brief understanding, there is something which is known as supervised learning. Like for example, the gastroenterologists, the young budding gastroenterologists are getting trained by the professors and by the faculty. So that's something like that. The data is given to the computer, fed in refined format. For example, the colonic polyps. I was involved in the development of one of the Google's polyp detection software. So I know we had been engaged in a continuous rigorous activity on labeling the landmarks. The first came the landmarks, then came the polyps, then came the abnormal polyps, and then came the type of abnormality, which is adenomatous or non-adenomatous. So that is feeding the computer with loads and loads of data in an organized way. So that is what is known as the supervised learning. Unsupervised learning, where the machine learns on its own. So machine is going to detect the patterns, and if you provide it with the final result. Here what I did was I labeled all the polyps, I labeled all the different landmarks and gave it to the system, and then it started learning on its own. Whereas the final result will be given and the basic data, raw data will be given. So the computer tries to analyze and understand based upon some patterns, etc. This is an unsupervised machine learning. So not going into the details. So semi-supervised is you have a hybrid where the computer does that unsupervised part and you give a partly fed data. And reinforced. This is very, very important. Reinforcement comes from the environment where we give a feedback to the system and the system understands and reanalyzes the final output and finally gets back to the understanding that, okay, this is this particular entity and it's another type of learning. So, are we using machine learning in our day-to-day life? The answer is yes. We might not be knowing about this particular aspect, but yes, this facial recognition in our own phones, the image recognition, your voice recognition is all example of machine learning. For example, if you switch on your new phone, it will ask you, for example, Google will tell you to read out a particular thing. Like for example, it will say, please fix an appointment at this particular time. It will give you 5 or 6 different wordings and then it will ask you to speak, because that is what is machine learning is about. It understands the way you pronounce. Your pronunciation is understood by that. And people who use Dragon software, you understand that there is a 1-month training on Dragon software. It tries to understand the way you speak. And once it gets adapted to it, it recognizes it automatically. That is what is machine learning about. And these traffic alerts are again machine learning. The email spam filtering is again machine learning, because once you label it as spam, it will always go into the spam box. That's another type of machine learning. Now comes the last concept, is the deep learning. Deep learning is basically a reinforcement of what the machine learning does. I'll not go into the details, but I'll just show you this image. So deep neural networks, that means data is going on being fed to the system again and again, so that a final refinement of the output happens. So this is what about deep learning is. We will not go into the details because we are not into the engineering part of it. We will not be able to understand deep, but something deep learning is something like our reinforcement. We prepare for the exam, we do another preparation, we do a semi-final, and then we finally go for the exam. So something like that is deep learning. So machine learning and deep learning. In deep learning, there will be intraneural networks, something like our brain nervous system, where different connections are going to be there, and the data is going to be analyzed in different ways. So the first layer will be a combination from the basic motifs. Second layer will be they assembled into the parts. Third layer will be from other objects, parts will be picked up, and this is what is all about the large data sets. So this is what about deep learning is. So machine learning was simple, spam filtering, Google Maps and all. Whereas deep learning models are like our autonomous cars, the chatbots which we see, and the virtual assistant like the refined Siri and the Alexa. Now, a very brief into what AI can do in gastroenterology. We are going to hear from the experts, but it is going to identify the landmarks for us. It is going to assess the completion of the study. It is going to identify polyps as of now and label them as malignant versus non-malignant. And we have a few more areas where AI can help us in gastroenterology. The main aspects where AI is actually looking at is the topographical pattern, the color differences, the microvascular pattern, the pit pattern, appearance under NBA, and the endocytoscopic appearance. This is one very important area where AI is working in gastroenterology as of now. And we have many other areas where it can actually go into. It can go into early cancer detection. It can go into the invasion of the depth. It can identify the lesion, delineate the lesion for me to help me to do an ESD properly. Even though my endoscope, my eye is not able to see properly, the AI is going to help me map the disease in a much better way. I'll stop with this and we'll now hear from the experts about the AI. I would like to invite Dr. Akira Dobashi to give his lecture on AI in upper GI part. Sir, you have your laptop. Huh? I think, I'm sorry if I had used a lot of jargon which doctors and gastroenterologists like us may not know, but I thought that this was important for us. Otherwise, today's talk will be just a super flow of things that, okay, AI is there, we are using the polyps detection software. I didn't want us to go back with the same thing. We have been using machine learning, we are using deep learning in our day-to-day practice, and there is a lot of scope for us to use all these things in gastroenterology also. Yeah, it has come. I think before it starts, I'll give a brief introduction. Dr. Akira Dobashi is the unit head, Department of Gastroenterology in the JK University, Kashiwa Hospital, Japan. He has a relentless drive for the knowledge and expertise. It has come, right? Okay. So I invite you, sir, for guiding us in AI in the upper GI gastroenterology. we look forward to hear from you, sir. Right, thank you.
So hello everyone, I'm Akira Dobashi from GK University, Tokyo, Japan. So it's great honor to present my lecture and share the knowledge about gastric cancer today. So I extend my gratitude to everyone and all the attendants and the Fujifilm staff for making me to share opportunity to share the lecture. So first of all, I want to introduce myself. I was born in 1980 in Yamanashi Prefecture, where the Mount Fuji is located. Mount Fuji is the highest in Japan, highest mountain in Japan. My research field is the diagnosis and treatment of the esophageal cancer and gastric cancer. So those are topics of today's lecture. There are many things for the lecture. At the beginning, I will explain the knowledge about the gastric cancer because before to make the most use of the AI, you need to knowledge about gastric cancer. And yes. So first of all, I want to share how to perform the endoscopy effectively. So for detecting early gastric cancer, we should observe the whole area endoscopically in the stomach. However, there is no standardized method to mapping or to enter the stomach that is accepted worldwide. So in Japan, we developed a systematic screening protocol for the upper GI tract, and the most endoscopies observe the stomach according to their protocol. So I would like to share the video of the screening endoscopy in the stomach. So like this, you should observe the whole stomach with forward and retroflex views. So this artificial intelligence has functionality of landmark photo checker, and the AI can recognize what has been observed and what has not. So after the observation of all area in the stomach, landmark photo checker here, excuse me, this is a landmark photo checker, give you a sign of completion. If the AI have not evaluated the completion or the observation, you may need to observe the area that the landmark photo checker doesn't give you a sign of completion. So in this lecture, I will use those anatomical terms. Those may be different terms from the Indian endoscopists, especially for the angle and the fornix. We call it this area, excuse me. Anyway, we call it this area angle and the fornix for the Japanese endoscopist. Okay. So those are images. Please make sure those images with the handout I have already provided for the WhatsApp. So those are images for the pilus and the antrum. So if you take a picture like this high quality image, you can avoid to miss out. You can avoid the overlooking the missile lesion. So this is an image for the angles. This is an image for the lesser curvature of the gastric body. This is an image for the cardia and the fornix. And those are images for the posterior wall of the gastric body. A posterior wall of the gastric body is one of the challenge to observe in detail because always this area becomes a tangential view. So after the observation with the retroflex view, I always take a picture from the forward view like this picture. So those are many pictures for the for screening endoscopy with to keep the quality of endoscopy. So the first topic is how to detect gastric cancer. So before the lecture, I would like to show the characteristics of gastric cancer. So I will explain the characteristics of gastric cancer based on the histological type, including the intestinal type and the diffuse type. Those are a summary and the image of the each type of gastric cancer. So I will explain in detail. So those are images of intestinal type gastric cancer. Cancer cells exhibit dense and expansive growth compared to the normal tubular structures. So it also characterizes the presence of blood vessels in the intestinum compared to the normal tubular structures. So these intestinal blood vessels are thought to be involved in tumor redness. So the most of intestinal type gastric cancer shows redness. And one more important thing is those intestinal type cancer arise from the patient with Helicobacter pylori infection. So unlike the intestinal gastric type, the diffuse type gastric cancer does not create tubular structures. When there are no erosion or ulcers, intestinal angiography is rarely involved. Thus, the lesion appears whitish. Some of the patients without infection of the Helicobacter pylori, this diffuse type gastric cancer occurs. So if you look at the patient whose gastric mucosa is normal, that means the no infection of the Helicobacter pylori causes such kind of the diffuse type gastric cancer. So this is a definition of the microscopic type of early gastric cancer. The morphology is broadly divided into three types: 01, 02, and 03. 0 means early cancer, whose invading depth is up to submucosal. And 02C is divided into three types: 02A, 2B, and 2C. 2A is a superficial elevated type, less than 2 millimeter in height, and 02C is a superficial depthless type without ulceration. Once the ulcer occurs, the lesion is classified as 023. So I showed some representative case on the right. So those are the points to detect early gastric cancer. These characteristics must be kept in mind during the screening endoscopy. I found the lesion by combining those appearances. The first point is color change. You can find the reddish area. The histology shows the mucosal adenocarcinoma 6 millimeter in size. And you can find the whitish area, can find the region in this picture. As I explained, the diffuse type cancer lacks vascularity and shows the whiteness. So if you find the color change, it's very important to identify the lesion. Irregular surface is another point to detect the gastric cancer. So under BLI, the structure on the surface is enhanced. The BLI may improve the detection of gastric cancer. So sucking the air can enhance the depression. So changing the volume of the air is also effective in identifying the lesion. So you can identify the reddish area. After sucking the air, the depressed area is enhanced and the surface shows the irregularity. So therefore, if a lesion is found, adjusting the air volume is effective for finding the lesions. So blood vessel in the submucosal layer can be observed on the mucosal surface with the patient with atrophic gastritis. So if you focus on the center of the lesion, there is we cannot see through the submucosal, the blood vessel in submucosal layer. So we can identify the lesion like this. So you are focusing on the background mucosa is very important. So oozing bleeding is an easy sign to recognize a lesion. So gastric cancer occurs bleeding because the structure between the cancer cells are weak. So next topic is how to diagnose gastric cancer endoscopically. So some gastric cancer appear to be benign lesion and vice versa. So Fridge developed the AI-supported new system. However, the system can detect the lesion. However, this system cannot do the differential diagnosis so far. So we have to diagnose the lesion by yourself so far. So when it comes to the differential diagnosis, histology is a gold standard. However, you cannot biopsy from the older lesion. So so you have to identify which lesion should be biopsied or not. And Japan Gastroenterological Endoscopy Society recommends the algorithm based on the magnified endoscopy to perform the differential diagnosis. It is called the magnified endoscopy simplified diagnosis algorithm for early gastric cancer. It's a long name. We call it the MESTA-G system. So I will explain how to use this algorithm. The first step is to identify a demarcation line. So demarcation line may become unclear under white light imaging. On the other hand, the BLI may improve the visibility of a demarcation line. A demarcation line, magnifying endoscopy is not always required for the evaluation of demarcation line. The first step is to identify demarcation line. The demarcation line corresponds to the boundary of the lesion between the gastric cancer and normal mucosa. Histologically, it is recognized as a front. The second step is evaluation of the microvascular pattern and the microsurface pattern. Each finding is rated as regular, irregular, and absent. So in this step, magnifying endoscopy is needed. So those images show the demonstrable cases of the microvascular pattern and microsurface pattern. So please make sure that each image with the handout I have provided. The image on the center is irregular, and the image on the right is absent. So you should evaluate this image according to these demonstrable cases. So I will explain how to evaluate those patterns. There is an image of the magnifying endoscopy with BLI. Irregular microsurface pattern is evaluated comprehensively based on the morphology, distribution, and arrangement. If you divide the image into the 4 equal parts, you can evaluate those features, and you can evaluate the microvascular pattern irregular in this case. As we did for the evaluation of microvascular pattern, microsurface pattern is also evaluated comprehensively based on the morphology, distribution, and arrangement. If you divide an image into 4 equal parts, again, you can evaluate microsurface pattern as irregular in this case. So I will show you some cases. I found the depressed lesion at the lesser curvature of the gastric body. Under BLI, with magnification, I evaluated the lesion as having a demarcation line, and the irregular microvascular pattern, and the irregular microsurface pattern, and the magnified endoscopic observation. The histology by biopsy showed adenocarcinoma. So I found a small depressed region at the lesser curvature of the gastric bundle. I evaluated the lesion had a demarcation line, but had a regular microvascular pattern and regular microsurface pattern. The histology by biopsy showed the gastritis. So this is a simplified criteria. So there are some doctors say this is a regular microsurface pattern or something like that, but we have to evaluate the lesion with a background mucosa or something like this. So we have totally evaluate. This is one of the features of the cancer region. So we have to diagnose the lesion with comprehensively. Although I mentioned the magnifying endoscopy is necessary for different diagnoses, some lesion can be differentiated without magnifying endoscopy. If you find a reddish depressive lesion, change the modality from white light to BLI. Demarcation line and surface pattern can be evaluated. The lesion didn't have a clear demarcation line and had a regular surface pattern. So I determined this lesion was not gastric cancer, and I omitted the biopsy. So the next topic is high-quality screening endoscopy. If you want to detect early gastric cancer, you need to keep these points in mind. So I will explain the benefit of AI, but there are some things that the AI cannot support. We have to overcome this issue by yourself. The AI can detect the lesion. However, you have to manipulate the endoscope by yourself to show the image to the AI system. So the first thing to do is remove the mucus. So it is necessary to clean the gastric mucosa and remove the mucus and bubbles. Otherwise, gastric cancer behind the mucus can be easily overlooked, even though you use the AI system. I think this is the most important thing. In this case, removing the mucus made it easier to find a lesion. So I heard that you can use the Imagecon to reduce the bubbles. So I highly recommend you to use the Imagecon for the screening endoscopy. So the second point is knowledge of the blind area in the stomach. The anatomy of the stomach is complex. The shape of the endoscope changes depending on the amount of air and the endoscopic procedure. So there are some areas that are difficult to observe. So it is necessary to be aware of these issues and actively operate the endoscope. In general, if you look at the thin object from the side, you will miss them. To avoid overlooking the lesion, you should observe the gastric wall vertically like this. So I will explain the foreblind area. There is, this information has already contained in the handout I have already provided. So the first area is the, between the angles and antrum at the laser curvature. The lesion is not visible when viewed with the forward view. So you need to push the endoscope in by recognizing that you cannot see clearly in this area. If you cannot make the distance between the tip of endoscopy and the gastric wall, I recommend you to push the end of the endoscope more, like this. Please push a little bit more. So I will demonstrate this procedure in this case afternoon. The angle area may not be observed properly. So in this image, the posterior side at the at the angle is blind. So you need to recognize that the area is difficult to observe. The image on the left is another case with a lesion in the posterior side at the angle. There is a depressed lesion, and biopsy on the lesion shows the gastric cancer. The second area is the lesser curvature of the cardia. Can you identify the lesion? The lesion easily hides behind the endoscope, especially at the cardia. So you have to observe this area carefully. The cardia should be observed with the maximum angles with the tip of endoscopy. So please use the right angle as well as the upper angle. So the tip of endoscope can twist like this, and you can observe the cardia side well. Even though the endoscopist might have satisfied with the observation of the cardia, there was a lesion behind the endoscope. So you have to be careful in this area. The third area is the posterior wall in the gastric body. So in general, the observation on the posterior wall tend to be more tangential than observation of the anterior wall. So we should observe the posterior wall with the forward and the retrofixed views at the same area. I also demonstrate how to observe this area with the actual case. The last part is the pilus and prepilus. So observing the pilus in this way makes it easy to miss lesions. So 1 year later, the patient was diagnosed with gastric cancer. So you should center and observe the pilus like this image. So please make sure those high quality image with a handout I provided. The image on the left is not good. There was a tumor at the greater curvature side. So you have to observe this area carefully. If you get too close, you may miss the lesion too. An appropriate distance is also important. So return to the key points to high quality screening endoscopy. The last point is appropriate amount of air. If there is an insufficient air volume, even advanced cancer may be overlooked like this. So the gastric mucosa between the fold should be carefully observed while inflating sufficient air. Otherwise, you will overlook gastric cancer. So there is a pale depressed lesion between the fold. I think some patients cannot resist burping. In such cases, ask the patient to look down or let the nurse put the pressure on the thyroid cartilage with their fingers. So we have to expand the stomach appropriately. So let's move to the topic of the AI. Excuse me. So Fujifilm developed an excellent endoscopy system which has a functionality of AI support. So like this, the AI system can detect early gastric cancer by box. If a lesion is likened to suspect, then AI is likened to police officer. So AI can arrest many gastric cancer suspect lesions with high sensitivity. However, not all lesions detected by the AI are gastric cancer. So we need to diagnose gastric cancer endoscopically. So we need to select or judge the lesion whether we should take a biopsy or not. So I will share the video on how to identify the lesion using the AI system. The AI works under white light imaging or LCI in the stomach, but not under BLI. So BLI should be used to evaluate the demarcation line or a microsurface pattern or a microvascular pattern. So I will share another case. There is no color change in the lesion. However, the AI could identify the lesion like this. By switching to the LCI, the lesion turned a color change. So I think the LCI may be more comfortable for you. After detecting the lesion, please change the modality to BLI. Then you should identify the demarcation line. So even if AI system is used, it is not possible to make full use of AI in such situation. For example, there is a bubbles. The AI cannot detect the lesion. So do you think this observation method is sufficient for observing the pilus? The AI system has not detected any lesion yet. The AI has not evaluated the completion of observation of the pilus with the landmark photo checker. So it is necessary to observe the pilus with a center position. So by doing so, the AI can detect the lesion. Right. So as I explained, please observe the pilus until the landmark photo checker will give you a sign of completion. When the AI system detects a lesion, you need to evaluate whether a biopsy is needed or not, according to the methodology system. However, I don't think you use magnifying endoscopy in every case for screening. So I use the following method to decide whether to perform biopsy when I don't use the magnifying endoscopy. If the lesion doesn't have demarcation line, nor having irregular mucosal pattern, I will not take a biopsy. That's because I can determine the lesion is likely to be a benign lesion with a high confidence level. If you evaluate the lesion is likely to be a benign lesion with low confidence level, like this region, I will take a biopsy because there is a chance, there may be a possibility that the lesion is gastric cancer. So I will also take a biopsy if the malignant lesion is suspected, regardless of the degree of confidence. So the last topic is the detection and diagnosis of the esophageal cancer. Unfortunately, this AI system is not supported for the Barrett esophagus. However, this AI system is good functionality to detect squamous cell carcinoma. So as you know, the BLI is a powerful tool for detecting esophageal cancer, esophageal squamous cell carcinoma. So please observe the esophagus with BLI. Once you detect the brownish area on the BLI, the lesion may have potential of squamous cell carcinoma. Those images have already contained the textbook I provided. So this is another case. So of the esophageal squamous carcinoma, it may be impossible to detect the lesion under the white light imaging, the image on the right, image on the left. So this is why BLI is a powerful modality for detecting squamous cell carcinoma. Those are the target lesion for you for the screening endoscopy. So let's see the actual case. In the esophagus, AI doesn't work under the white light imaging. So please observe the esophagus under LCI or BLI. So by switching to the LCI, the AI can easily detect the lesion by a box. The BLI can also detect the lesion like this, like a box. So I always insert the endoscope with the BLI mode to observe the esophagus. If you have a magnifying endoscopy, please observe the microvessels like this, so you can identify this very squamous cell carcinoma. So actually, I evaluate the lesion with magnifying endoscopy according to this classification. So this slide shows the Japan Esophageal Society classification. So we can also perform the different diagnosis according to the classification. However, magnifying endoscopy is also needed for the precise diagnosis. So if you use the AI system, please take a biopsy from, if you find the malignancy suspect lesion, such as the brownish area under the BLI, or lesion that is detected by the AI system. So this classification has also contained in the textbook. So this slide shows the steps of practical screening endoscopy with AI. So please use BLI or LCI in the esophagus. And then once you enter the stomach, you use the white light or LCI. In the stomach, you should wash the stomach and remove the mucus and bubbles. Then please observe the stomach carefully. I recommend observing the stomach for 5 minutes if the patient has atrophic gastritis, because atrophic gastritis is a high risk for indicator for the high risk for the gastric cancer. The landmark photo checker will support the quality of the observation. Once AI detects the lesion, please perform the different diagnosis and take a biopsy according to the diagnosis and your confidence level. So I have some quiz for the detecting early gastric cancer. So I will show the plain image first, and then I show you the answer with the AI system. So the LCI may come through for you to detect the lesion. So now you can identify the lesion, I think. So this is the answer. To surprise, the AI can detect immediately once the lesion is in the image of the endoscope. So this is I used the non-magnifying endoscopy in this lesion. So after detecting the lesion, I switched the modality from white light to BLI, and I evaluated the demarcation line. If we use the high definition endoscopy, you can also identify the demarcation line without magnification. You can also evaluate the mucosal pattern, regular or irregular, under non-magnifying endoscopy, so you can evaluate this lesion as a possibility of gastric cancer. So let's move to the second case. Let's find the lesion. So this is the answer. Before the lesion is behind the fold, the AI cannot detect the lesion. However, once the lesion is come to the proximal side, AI can identify the lesion like this. So you have to wait the movement of the gastric wall like this. You have to observe the whole gastric mucosa. So once you detect the lesion, please change the modality to BLI to identify the demarcation line. This endoscope is magnified function, so I observe the lesion with magnification. So there's a demarcation line, and the mucosal surface pattern is irregular. So take a biopsy, show the adenocarcinoma. So those are the lesion for you to. This is a target lesion for screening endoscopy. So I hope you enjoyed my lecture, and I hope you will be able to gain the knowledge for high-quality screening endoscopy with AI system. Thank you very much for your kind attention.
Thank you very much, sir. It was definitely an enlightening lecture for all of us. I think for my registrars and postgraduates, every lecture you will be having a lot of information flowing through, but if you give micro importance to every slide what sir has told. Like for example, today I'll tell you the learning point apart from the BLA LCA images, a very important point. I always wondered why, how to adequately distend a gastric stomach. I initially thought that we were doing under anesthesia, without anesthesia, the patient is burping out. So, but I had this problem even when we are doing under anesthesia. Sir told a very simple trick of applying a thyroid cartilage pressure. So, I think these are the subtle important findings in everybody's lecture. So, you have to pay attention, especially for my postgraduates. Please pay attention to each and every slide. The second important thing which I learned today and which is all important, AI is not going to drive on its own. You have to give yourself adequate amount of time. If the lesion is behind a fold, it cannot be detected by AI. That was the wordings which sir has used. So we have to wait for the lesion to appear in front of the AI. So we have to do the procedure properly ourselves, then only the AI is going to aid and help us in getting it. Thank you, sir. It was a very well enlightening lecture. Thank you. Please, okay. Sir, we'll have it after this. Sir, thank you, sir. Welcome to us. We'd like to welcome our faculty, please. Dr. Rajkumar Wadhwa. Sir, thank you and welcome, sir. Professor Jagannath Mondal, sir. He is from Tata Institute of Fundamental Research. Professor Atul Negi, sir, from University of Hyderabad. Professor Shravan, sir, head of the department, Gandhi Hospital. Dr. Ajit Kumar, sir. Sir was my teacher in Nizam's Institute, and I am very happy to be associated and working with sir. Professor Ramesh Kumar, sir, from Osmania Hospital. Dr. Umadevi, madam, professor in Osmania College, present HOD. Yeah, please. Madam, please come. Sir, I will load the lecture. Thank you, ma'am. Thank you for accepting and coming for the slide. Dr. Sedhu Babu, sir. Sir. No, sir. Sir is our, he is the AI for gastroenterology department in the hospital. He questions each and everything in the positive way, in the negative way, and he gets the best out of all of us. Right. Thank you. Dr. Ramakrishna, sir. Dr. Sudhir. Sir, please. Sir is a gastroenterologist, and now he heads the two divisions of KIMS Hospital, KIMS Gachibowli and KIMS Kondapur. Thank you, sir. Thanks for coming.
Thank you. I can see so many young minds and budding minds. Of course, welcome all. First of all, congrats to Sreekanth for putting a fantastic conference together. And I think the support from all the departments is overwhelming, including the juniors and the seniors. Welcome to the faculty, sir. We would not have been able to make this a grand success without you. On behalf of KIMS and on behalf of the organizing committee, welcome all. Thank you.
Thank you, sir. Now we move on to the next lecture by Dr. Rajkumar Wadhwa, sir. I had heard about Wadhwa, sir, somewhere close to 2000, early 2000. I was closely associated with the Department of Gastroenterology in Vizag, sir. We had our beloved teacher, Dr. Murali Krishna, sir, who is no more amongst us, but he is one of the pioneers in double bill endoscopy. So we used to keep hearing from Murali Krishna, sir, about Wadhwa, sir, because both of them had pioneered and started double bill endoscopy in India. They were the first persons to use double bill endoscopy in India, and I used to keep hearing about sir. Sir is an expert in double bill endoscopy, and I had actually seen him as an undergraduate. Actually, that's how inspiration comes from. I had seen sir performing procedures when I was an undergraduate in Andhra Medical College, and some part of the inspiration of my gastroenterology also is owed to Ratha sir. Sir, please enlighten us about AI in colonoscopy.
Thank you, Sreekanth, for the kind words and your invitation to be a part of this wonderful gathering. I started doing artificial intelligence using artificial intelligence about 2.5 years back. And the journey has helped me understand some of the aspects or nuances of colonoscopy, because that's where this was the area where the first AI was launched in endoscopy. I'll start with a statement which probably, would like to take all your actions with. What do you think of this? This is for the reason which Sreekanth described in his first slide. But no, that is not true. I don't believe that this will happen. But what will happen is this. It is not going to replace the doctors, but those who learn the AI will certainly replace the doctors who don't learn the AI. So it is a necessity for us to be a part of this new generation endoscopy, for us to survive and thrive both in this competitive world. As far as the colonoscopy and adenoma detection rate is concerned, that's of the context in the treatment of the cancer. This paper from United States clearly validated the concept that adenoma carcinoma sequence, which happens if you detect the adenoma early, resect it out, you are actually preventing the cancers. And this is why there are a lot of efforts being put to find out more and more adenomas while doing a colonoscopy. There is another thought process that, yes, detecting adenomas is one thing, but what about the miss rate at the colonoscopy? That also amounts to the same thing. If you do not pick up the adenomas, our adenoma miss rate also is, and when we do a colonoscopy, we miss about 20% of adenomas in this situation. That increases the interval cancer. It is looking at the same aspect on plus side and a minus side. There are a variety of factors which leads to these kind of things, both adenoma detection rate or a miss rate, in other words. These are, when do you start the endoscopy or colonoscopy, how tired you are by the time you do the colonoscopy, whether you are doing in the morning or evening, what number of procedures you are performing. As in the graph, you can say that how is your withdrawal time of the colonoscope. As the day passes, your withdrawal time decreases. You take much longer time in the morning when you start doing a colonoscopy, much shorter time in the evening, and your adenoma detection rate comes down as the day passes. So there are a variety of human factors which are involved in detection of the adenoma, and if we can overcome these human factors with the help of a technology, then we can certainly improve the adenoma detection rate. Not only the withdrawal time or the human factor of the fatigue and focus of the endoscopist, overall composite measures of endoscopy, which included the colonoscopy or rather cecal intubation rate, the comfort of the patient during the colonoscopy, that is which is measured by the nurse in this particular study, demonstrated that only about 54% of the patients who underwent a colonoscopy had this composite PK score achieved. So nearly half of the patient has one or the other difficulty. Either you are not able to reach cecum, or you have a lot of sedation being given to him, or patient is in discomfort during this period of time. That enhances the adenoma miss rate. So adenoma detection rate is significantly higher in those patients who had a comfortable PK score rather than those who did not have it. So there are factors which go beyond the endoscopist or beyond the colonoscopist. So how do we improve this situation? You can improve this situation by training the doctors, or you can add the technology to help thing. The advantages of technology when it gets added, that it should be easy to adapt, or what factors which we will need in the technology to be added for improving the adenoma detection rate. It should be easy to activate and deactivate. While you are doing a colonoscopy, you should be able to put it on and put it off. You should improve, it should not exist the existing proven factors. Like you do a colonoscopy, the way you are doing, you should continue to do the same. We are not going to learn in a different way. It should not be limited by patient anatomy. It can either be additive or a magic bullet option. Quick addition to what you are doing, and you get an answer to the problem which you are having it. And it should help improve the focus of the thing and reduce the fatigue. There, for example, by reducing the time of doing a colonoscopy, you reduce the fatigue, and by putting certain measures so that you can focus on what you are doing rather than getting distracted can be the part of the technology. There are certain anatomical factors which also increases the adenoma detection rate, that is the presence of flat lesions and the lesions present in the blind area, like in behind the folds, and those things could be looked into. So there are many factors which can determine the adenoma detection rate. Avoiding a full day session, you do for a 4 hours colonoscopy and then somebody else comes and does it. It doesn't matter whether you do it, whether you do in the morning session or you do it in the afternoon session, but don't do it from morning to evening. Do not put the delays in starting, minor irritation. It functions on your brain. Of course, the procedural tips will be that you have to have a proper bowel preparation, which is an important aspect of any detection of lesion. You do not have a clean area to see, you miss lesions behind it. Withdrawal time, we all know that minimum 6 minutes of withdrawal time is what is required, and we tend to focus on that withdrawal time, and every minute increase in the withdrawal time increases the adenoma detection rate by about 3%. You can have a double pass or second look in these situations. You can add certain things like simethicone for clearing the mucosal thing, and you can use water immersion technique to improve the vision, which gives a significant advantage. Here comes that you can add the technology. We all know that we have had an image enhanced endoscopy adding to our repertoire of detection of adenomas, and we will discuss some amount of it. And finally, to add artificial intelligence to help get better in this particular technology. Now let us look at the technology first. The first is the image enhanced endoscopy. All of us are familiar with the terms of NBI or BLI. These are all actually wavelength detection based. That is, the change of wavelength in the color pattern enhances the contrast of the blood vessels and thereby gives us a better contrast of the lesion. We know two important things. One is an NBI and a BLI. However, application of this, while is useful for characterization of lesion, it does not help in improving the detection of the lesion. You are not detecting more lesions by putting an NBI or BLI as compared to a white light endoscopy. So yes, you can detect what type of lesion it is, but you cannot say I have detected more lesions just because I have put an NBI and BLI. So for that, the technology which is useful is what we call it as link color imaging, where you have the same light spectrum which is widened up and it enhances the contrast. That is, the white becomes whiter, the pink or the color pink becomes darker pink, and the edges becomes much more sharper to identify. And this particular thing enhances the rate of detection. So you have a technology which actually helps in getting an idea about the lesion, as some of the videos in upper GI being shown to you, where the lesion on the white light was difficult to discern, but as soon as you put an LCI, the contrast enhances and you can pick up the lesion, and that's how it becomes. It is now multitude of papers are available which helps, which has given us the idea that how does LCI perform. It helps in increasing the sessile serrated adenomas. It helps in non-granular flat lesion detection. And in crossover studies, when you look at it with white light and compared it with LCI, you found that you had an enhanced adenoma detection rate. Enhanced median adenoma pickup rates are also improved. And technology has helped the non-experts more than the experts in actually increasing or enhancing the number of adenoma detection. This is how you will be able to detect the adenomas when you put it. However, if we add a technology of artificial intelligence, which can be divided into two subdivisions, that is a CAD-EYE and a CAD-X. CAD-EYE, where we primarily are looking for enhancing the detection rate, and CAD-X, where we are actually looking at classifying this type of adenomas which has been detected. Since this lecture primarily deals with the enhancement of adenoma detection rate, we'll try to focus on that particular technology. In 2018, Urban's paper in Gastroenterology gave us an idea that the deep learning methodology, if applied, that is the images when given to a computer and formed a data set, accurately detect or enhance the number of the polyps in the what benefit does it we all know that it can improve the polyp detection rate. It when applied with a CAD-X technology can enhance the detection or characterization of this, and so that we do not miss a high risk lesion, and it contributes to the reduction of pathology and cost of low risk. We will discuss why we can do that as we go through this lecture. The same paper actually highlighted that you are detecting overall higher number of adenomas when you apply, but this benefit focuses on smaller adenomas more than the larger adenomas. As you can logically understand that larger adenomas will be more easily picked up by the white light endoscopy with naked eye, but the smaller adenomas or flat adenomas or adenomas behind the folds are more likely to be missed. AI cannot do anything about the adenomas behind the fold as we can see that, but it certainly can enhance the smaller lesions to be detected much more faster as compared to the larger lesions. So we can say that there is an overall clear benefit of the CAD-EYE application across the site size and the morphology. The overall adenoma detection rate is significantly higher with those which have applied the artificial intelligence, but the biggest benefit comes when the adenoma size is smaller than when it is bigger. Do we need to prove the effect on non-expert colonoscopies? While it increases the adenoma detection rate significantly in non-expert colonoscopy, there is a marginal benefit for this even with those who are generally an expert on that. The benefit is not as wide as we are seeing it in the younger. Is the fear of losing the technology, of losing the skills by using this technology valid? To some extent, cognition bias can be there. Our capacity to detect adenomas over the time may go off, but I don't think it will reduce the patient benefits. You can take an example. You were learning when you were in your 4th or 5th standard by mathematics by doing practicing the tables in your mind. Calculator came by the time you came to your engineering colleges and you stopped doing it with your mind. And now if you are suddenly asked to do, you do not do it with that kind of skill which you were doing it when you are younger. So yes, there is a probably decline in the skill, but it has not hurt your outcomes. What I'm trying to say is the patient benefit is significantly more when you have applied these technologies, and these technologies are going to be a part of our life as we go forward in a day-to-day method. Just to understand what these things are, in LCI when it is applied to it is AI, it is a detection mode. That is, we try to detect the lesion when an LCI is applied. When we shifted it to BLI, we actually go into what we call it as characterization mode. That is, we look into whether these adenomas are hyperplastic or neoplastic or adenomatous type of polyps. This is a very simple technology which can be put onto the endoscope. You have these switches available on the endoscope. One of the switch on the top actually activates and deactivates this technology. So you press a button, you have a CAD-EYE on, you press a button, you have a CAD-EYE off. And another switch actually modulates the type of CAD-EYE which you are using. You have the detection mode first, which goes with LCI. The second mode is BLI, which goes into characterization mode. And how does it, what are the responses or reaction? Whenever it detects a polyp, there will be a box or a square which will be pointing towards the lesion. This is the area where we are looking at improving the focus of the endoscopist. You point a lesion towards the polyp. As you saw in the previous video, there is a box which comes and determines that. You also have a visual assist circle. There is a line on the corner of the endoscope which actually starts blinking to get an attraction towards you, that you look towards that area. This is the area which possibly has an abnormality, but both are visual perceptions. You may be talking to somebody, you are bored at the end of the day, 8th colonoscopy or 10th colonoscopy you are doing, you are talking to your nurse telling her that adjust this position or adjust that position, and a polyp passes in front of your eyes. Even the visual thing can't attract your attention, so you have an auditory response coming behind with a noise coming that there is something wrong. It attracts your attention back. These are the efforts to improve your focus onto the area of pathology which you are looking in, and then it helps. Once you have identified a polyp, you switch on to a what you call it as a characterization mode, and in the corner you will see that there is a box which comes through. It gives the polyp at the polyp site, whether it is green or yellow. A green is hyperplastic and sessile serrated adenoma, while a yellow is an adenomatous polyp. Just to understand that in the real life sequence, you can see the visual markers. You can once an LCI is started, you will see the visual assist circle and over the polyp the characterization of that polyp coming through. So it gives with a fair degree of confidence that you have this is a neoplastic polyp rather than a benign polyp or a hyperplastic polyp in these circumstances. I have had an instances where in the same focus you can have one hyperplastic and one adenomatous polyp, and you can detect the same with the similar situation. Does improve adenoma detection rate makes a difference to the patient? Immediately may not be no, but in the long run to reduce the interval cancer, yes. Does it increase the save lives? Yes, we know that with the interval cancer the lives can be saved and eventually the benefit can be of the patient. Can CAD-EYE be implemented at all? Yes, we have a certain standards produced by the ASG to have a certain amount of competence level, which this particular software will touch that level. Yes, we have now enough studies available to guide us that it touches that level, and you can put it for all. Does it have any other benefits? Yes, if you look at in the large screening programs, it reduces the cost of the detection of the polyps, as well as the improves the environment. Now, all this is based on the fact that the lesions are measured. I use the word we will reduce the burden of a pathologist. And how do you reduce the burden of pathologist is you have two policies which we work on it. That is leave in situ. That is when you know that this is a small polyp, this does not has a malignant potential, you just don't touch it, you just leave it inside. Or resect and discard. You have a slightly larger polyp, you are very sure that this is a benign polyp, you don't need to even send it to the pathologist to have a biopsy proven, thus thereby reducing the cost in overall cost as well as the healthcare burden of analyzing these lesions over a period of time. But there are certain standards to be met before these policies can be given. There are bodies which have given us the standardization that you need to have at least 90% sensitivity and 80% specificity of the diagnosis unless and until you put this policy in picture. And can this be used for that? So yes, we have reached a level of 90% sensitivity and 80% specificity to get the outcomes what we desire in these circumstances, to put this into perspective. We had initial skepticism that all the polyps which have been given as a data set to these patients are actually Western data sets which have a much higher incidence of cancer as compared to the Indian data set. We have done a study here in India, and which almost matches with the figures which we have got on the Western data set. But how do we accurately identify the size of the polyp? We have an approximation. Senior or experienced colonoscopist will tell you this is an 8 millimeter polyp. By looking at the polyp, you may put on a biopsy forceps inside, open the biopsy forceps, take a size, you may put in a snare inside with the diameter and you may assess the thing. But you know that the polyps which are actually seen inside at a different angle, any round structure at a different angle based on the penetration diameter, you can have a different diameter. So exact assessment of the diameter now is possible with the help of artificial intelligence. This is called as a scale-eye, where you use a laser pointer to the end of the polyp and then a scale is placed across you to get it, whether it is 5 millimeter or 10 millimeter polyp, and then with the help of the CAD-EYE and CAD-EYE to classify the polyp and to say that I will resect it or throw it off, I will resect it, send it to the pathologist, or I will just leave it behind in that manner. Does it have its limitation? Yes, it does have its limitation. AI can only see if we expose the mucosa. Any artificial intelligence or any machine learning is based on what you give the data to the machine. That's the limitation of any artificial intelligence. Garbage in, garbage out. So you are giving a poor data, you are going to get a poor answers to it. You are not going to get a good answers to it. So what about the increased adenoma detection rate when we are looking at the areas which are blind to us, where we can't see? We can't see, machine cannot see, machine cannot detect more. So you need to add certain technologies to improve that. So fold flattening technologies are some of the things which we have looked. Have we reached the optimum? I'm not sure about it. But there are a variety of methods which we have used. I'm not going to go into the details of it to flatten the folds when you are coming out. There's a technology called as now GI, which you has a balloon on the scope just proximal to the visual section of it, so that you inflate the balloon and you keep flattening out while withdrawing, so that the flattened folds can be seen across, and thereby it increases the visualization of it. Where tandem study using the GI technology has said that there is a significant improvement in adenoma detection rate if you use this particular technology. This has been proven in multi-center randomized control studies, and few meta-analyses have come out of it. But overall number of studies are not extensive. We still are limited to see the benefit. And Endocuff, which was the initial thought process on which the fold flattening technology was based, this GI has shown to be slightly superior to the Endocuff in that area. So what are the strategies to improve the ADR apart from the human strategies of reducing the fatigue, improving the focus, cleaning, picking up the patient with appropriate indication? You also have now the technology assisting you. The earlier way of looking at the endoscope can be replaced by these technologies of adding LCI to improve the detection rate, CAD-EYE to help us improve it, and further addition of this in the form of fold flattening technology. So the combination of different technologies will help us do better while we do the colonoscopy. Thank you very much for your patience.
Thank you, sir. Thank you so much for the wonderful talk and wonderful insights. Sir, we'll have some questions. Yes, sir. No problem, sir.
If you have this technology and you can leave the small polyps in, don't take them out. If they're small, don't bother about them. I beg your pardon and probably don't agree with that. At the moment, the indications are any polyp you see, you should remove it. There are two reasons for that. Number one, when the polyps grow in size, the possibility of getting cancer is increased, especially once it goes beyond 2 centimeters. So I don't know if you agree or you want to rectify the statement. I'll leave it up to you.
Sir, first of all, I did not say leave all the small polyps. I left, maybe I have given a wrong message in that order, but benign polyps of less than 5 millimeters should be left behind. That is, you have to first understand that these should not be adenomatous polyps. Adenomatous polyps are not to be left behind. So it is not that universally small size polyps should be left behind. That's number one. Number two, this message is not being given by me, but by the societies of which are building a long-term policy issues on that, which are coming out with this. I'm just the convener of the policies which is being developed. And it should be very clear that I'm not saying that the adenomatous polyps should be left behind, and there are still some skepticism in the world, real world, whether we should really be leaving this polyp or not. And we need some time to prove that this is what we actually would like to achieve. The purpose here is, if you know that this is a small polyp, especially less than 5 millimeter, it is a hyperplastic type of polyp, you are increasing both the not only the risk of the patient, where the chances of progression to malignancy is very high. Cutting a polyps is associated with complications. It is not that it is not associated, even though it may be very low, but it is still associated with complications. You are increasing the cost to the patient. You are increasing the burden to the pathologist. So there are positives and negatives to each way when we look at it.
Sir, comments from the faculty?
It's a very good lecture, Madhva sir. What I mean to say that artificial intelligence is a hand in hand is going to assist the clinician always. We should take it as assistant than it's a superior person. The other thing is that what I feel so that the adenoma detection rate per se, with a more over reporting of the polyps, is it so going to happen because of the every small minute things also the artificial intelligence is going to pick up. So are we going to spend more time for every minute lesions? Everything also we have to take into consideration. So our time of going for colonoscopy period also, the time for colonoscopy taking time might be going to increase the time of the colonoscopy time. So that's what I feel. So what's your say about this?
My partial answer lies to what I said, that yes, we are going to detect adenoma more, but we need to use it with caution, that if we characterize them as adenomatous polyp, you have a justification of removing it. You know, these adenomatous polyps are likely to progress, develop into, you have a risk of developing into cancer. If it is a hyperplastic polyp, I don't intend to resect them when they are very small. That's why currently, you know, my experience of the last 2 years says that after I started using artificial intelligence, I'm spending slightly more time than what I used to for colonoscopy. But I do believe that that time is well spent, because I now detect much more adenomas than what I used to detect. Possibly I was missing lesions at that point of time. So what you are doing is you are getting better, not worse, for spending a little more time inside the colonoscopy. No. Currently, still the biopsies is the gold standard. So, you know, when you are strongly suspecting a malignant lesion, or when you are, more than that, when you are in dilemma, whether it is benign or malignant, those are the areas where certainly biopsies comes and helps you out. So, no, they are not replacing the biopsies completely, only in a select situations.
Endocrine is another modality where the serrated polyp detection is very poor. What about this CAD-EYE?
Yes, sessile serrated adenoma is an area of concern, where majority of sessile serrated adenomas are actually benign. You know, very few are malignant. In this, it is being classified under benign lesion, and that classification is still not very clear, and that is why we are not getting 100% sensitivity in such topics. The difference between endobrain and this is, this gives you an absolute term, whether it is neoplastic or hyperplastic, while endobrain gives you a percentage of possibility of being malignant or benign.
Another thing is the position of the polyp you keep on your screen. Like it says you have to keep at 12 o'clock, then only whatever the output you get from the AI is better in 12 o'clock position. Is there any such thing in this?
There are certain criteria to get the best out of artificial intelligence. This includes the clean surroundings. You know, you should not be having a lot of fluid, fecal matter surrounding that. You're not. It's the data which we put in. Number one. Number two, it should be end on to the polyp and not at the angle, as sir has said, that vertical vision rather than a tangential vision. These are the two important parameters, and the object should not be moving in front of the scope. You know, you should not be having a variability of rapid movement of the scope for it to assess the image properly. once you achieve these two, you get a good outcome.
Thank you, sir.
Okay, I'll just give you the background of it. He was telling you how we use the AI. See, basically, he gave the sequence that he had first located the lesion, then they gave the annotation that this is a polyp, then gave the annotation whether this is a hyperplastic or a thing. This is far more simpler when you look at it in the polyps perspective. When you go into IBD, the annotations being given multiplies 1,000 times. You have to point out each and every locale of what different types of ulcer. You don't get a single type of ulcer. You also have to define how the blood vessels are on the surface of these. So the same level of difficulty which we are looking at in the polyp detection is far more difficult in other areas. Not that they cannot be done, but it is going to take time to reach the technology to that level. So while the studies are going on, you will find in the future of AI talk, you will have many of these things coming up. It does help in determining to a certain extent the activity of the ulcerative colitis or the activity of the presence of ulceration and healing of ulcers. But I do believe that we are not at that level when we can confidently say that this is ulcerative colitis, I put an AI and I'm answering you. As confidently as in this setting, we can say that, okay, this is a malignant polyp or this is a benign polyp. Yes, these are based on a combination of image-enhanced technology with the artificial intelligence. This is not in isolation. I'll just give you an example of what we are doing. Just give me. This is the color palette which we use for H. pylori detection. We are standardizing this color palette. The top two colors are for white light endoscopy, while the bottom four colors are for the Helicobacter pylori from normal, inactive, and active Helicobacter pylori infection. So what I'm trying to say is just to give you an example that you have a huge amount of annotation or marking to be going on before you actually say that this is what it is. So we will be there, but we are not there right now.
So, one question.
Just according to your this one of whether to leave the polyps or not, it is not like you can anywhere in the colon you can leave it. It's only applicable only to the rectal region, because in the rectal region more than 90% of the things which appear like hyperplastic polyps are likely to be hyperplastic. That doesn't apply when you go for the more proximal lesions, where even the less than 5 millimeter hyperplastic appearing can be significant numbers can be serrated polyps. So you cannot apply it there. It's only for the rectal regions. That's where you can.
I think we are walking on a very thin line here. You got to also keep in mind about medical legal thing. I work in Canada. You have to be very careful and not leave any lesion inside at the moment. Maybe in future we are there, I can understand. But at the moment, if you leave a lesion and you reported this is a lesion, I left it in, and God forbid it comes out to be malignancy, you will not be able to save your face anywhere in the world. One more thing I want to tell you is a new technology is coming. Your first slide was whether doctors are going to be replaced with computers or not. I don't think they're going to be replaced, but they are going to be reduced burden. A new machine and this experiments going on where you put the colonoscope into the rectum and then the machine drives it. And you just stand there and you see it. Where the artificial comes, it will stop there. If it on any fold, it gets stuck. You pull it back and it will take it through and the procedure would be done. and your technicians are more helpful to you. So anything like this, your burden can come down. But I agree with you, doctors cannot be replaced.
Yes, sir, very true. I think sir is talking about navigation AI. I think we already have navigation AI in a few sectors of medical field, neuro navigation. Palmo has got some navigations. I think Fuji is working on some navigation projects of GI also. So I think the future is going to be navigation based. I think one last question. This is from our live chat box from the live streaming from Dr. Srinu. Sir, for you, sir, what is the right way? Do we do white light endoscopy if we find something abnormal and then change to LCA, or complete examination with LCA?
So thank you very much for the question. Actually, I will use the BLI for the I will use the BLI for the inception of the esophageal first, and then switch to the white light image in the stomach. But the LCI is also the powerful tool to detect the early gastric cancer. So I recommend you to use the LCI after observing the white light imaging. So I always combine with the LCI and the white light, especially for the patient with high risk patient for gastric cancer, such as Helicobacter pylori infection. So the combinating the modality is better than the single use of the modality. Is okay?
Yes, sir.
Just to add answer to what Professor said, if I do an endoscopy, I normally will go with white light inside till duodenum. Once I finish the inspection of duodenum and come back into the stomach, we switch on the LCI. Thereafter, the rest of the entire thing is based on LCI and change to BLI whenever we find that there is an abnormal or suspected lesion is there, and then add magnifying endoscopy accordingly in that scenario. This is the general protocol which we will follow in both upper GI as well as colon. Colon also, you reach back to the cecum and then switch on to LCI and then come back. I hope you agree with me in that regard, in that situation. We normally don't use this technology in duodenum.
I think, sir.
Primarily for the stomach. As of now, the AI is only for the stomach.
I think the areas where BLA LCA is more useful is stomach, esophagus, and colon, sir, as of now. I think as technology evolves, I think one important aspect is we need to change, sir. Like our traditional thought process was doing a colonoscopy and completing it. Then came the concept of withdrawal time, improving the withdrawal time to increase the adenoma detection rate. So we have to spend more the amount of time, at least double the time on colonoscopy withdrawal. I think now the change is from white light to the special optical endoscopy. That is white light, BLI, LCI, NBI and all. So I think we need to change the way we are practicing slowly over a period of time. Things are going to change, and these are going to assist us in improving the healthcare of the mankind. So,
the thing is, these are all surface imaging modalities, and we don't find significant changes on the surface. What you are talking about neuroendocrine tumor or submucosal tumors.
thank you, sir. Thank you all for a wonderful participation, sir. Now we will move. Now we will move on to the inauguration with the Saraswati Vandanam. It's our tradition to memorize our God and then we and lighten up the diya. Sir, please. Sir. Please join us, sir. Sir, please.
शारदा
Dr. Akira, so this is our Hindu tradition, our Indian tradition to remember the god to lighten up the diya. So I was actually reading yesterday about Japan and its traditions. I think you follow Buddhism, right? More of Buddhism or more of Buddhism? Yeah, yeah. So I was just trying to understand what you people do before the conferences and do all those things to understand what the Japanese. Actually, why I was talking about all these things is we are coming up with an skill lab, sir. So we shortly in the next 3 months we'll be launching our skill lab here in association with Fuji, which will be a learning center for majority of us. People who are interested in BLA, LCA, we want to run a program in collaboration with Fuji and with great experts like you, where we want to expand and disseminate your knowledge to all of us. Practically, people who have been training with, like people like us who have been training are all trained in white light endoscopy. Because BLA, LCA or NBA were not available at the time when we were trained, or it's not very commonly used in our routine clinical practice. So I think there is a great depth of teaching lag behind in this particular aspect. EUS, ERCPs, and in fact, to that matter, even third space, there are a lot of people who actually train, teach. But when it comes to this optical endomicroscopy, that is this BLA, LCA, there are very few people who are real experts. I think we will need your help and expertise and people like you to help us in disseminating this knowledge. And in the next 3 months, we will be inaugurating our skill lab. We will again call you back. Please join us back for that inauguration and then help us in disseminating the BLA, LCA knowledge. I'm sorry we are not breaking up for a coffee break, but the coffee is available and the snacks are available. We'll move on to the interesting part. This is my area of interest. I'm sorry that I squeezed this particular aspect into the routine AI Academy program. This is a small discussion with our industry experts. Before I move into this topic, I would like to have some comments from both our professors who are there here, coming from University of Hyderabad and Tata Institute of Fundamental Research. Sir, your comments before we start this meeting and discussion about
it. Is very enlightening and a big revelation for me, and of course, I also understand that what the skill means. That just you are seeing some imagery and then somewhere you are identifying what is some kind of a lesion. All right, so I mean I am seeing the images, but I couldn't really make out what is there. So I think really the enhancement through the AI is really very important. Okay, I had a few fundamental questions like what if you change the illumination with a different wavelength? Does far infrared help? Does does ultraviolet a bit beyond the ultraviolet help? Okay, and why not even say like some kind of a microwave radiation which is going a bit deeper inside? Okay, so I mean these are all very research based questions which I have from an engineering point of view. One other thing is that can we think of, I'm sure that can we do a miniaturization and say have some kind of a mini robot which is sort of let loose in the place, and then that can really move around and try to get a full 360 degrees kind of a viewing and get the proper imaging. Okay, and that can be used to perhaps reconstruct and try to get a better idea of what is going on. There are just some kind of wild thoughts which I was having when seeing all of this. And one of the, from the AI perspective, my thought is that how do we get labeled data? All right, so you're having all these visual things, and then how do you get the labeled data that this is having a this is whatever it is, whether it is benign or not. So that I think so. The answer to that, he said that it is because of having specimens sent to the pathology. So I think so that is that. But as what you have said, that that happens much less often than as compared to so then there I have this doubt that how do we get that something which is seen and the spot, whether it is labeled, how is it labeled, so that is a fundamental thing. All right, so these are some thoughts which I had. Okay, it was really very enlightening for me. I thank Dr. Sreekanth for having me here. Thank you.
Thank you, sir. Actually, that was the essential thought process behind this roundtable meeting. We want to understand from the experts whether anything more can be done. We are already doing certain things on this. So your thought process that infrared, ultraviolet, those things probably we have few experts also from here. We want to actually understand whether we can do something more than these things. This brainstorming session, it's not to create some new concept, but we want to understand whether our ideas and our thought process is in the right way, whether industry can help us or not, whether the engineering experts say that we are thinking in the right process or not. This is what we understand. Sir, your comments.
Okay, so first of all, it's great to see so many medical doctors. So we are not really, I myself am not a medical doctor, but I do have a degree of, Doctor of Philosophy, but it's great to see. So, just to give you a brief background, I come from Tata Institute of Fundamental Research, which is closely situated, near University of Hyderabad. And that is a campus that has actually happened in Hyderabad about 5 or 7 years back, and we work on niche area in natural sciences. So when we call natural sciences, it comes under the domain of physical, chemical, as well as biological sciences. And my area of expertise generally belongs to looking at using computer and try to simulate biological sciences and look at, let us say, protein biology. So like many of you, I think I sort of got interested in looking into machine learning and artificial intelligence in the last few years. And what I found is that, like many of these ideas are to some extent very, while the topic of interest are quite different from what I do and what, today actually was discussed. But I found that there are significant number of analogy that one can easily draw in many of these aspects. And that is exactly what I was trying to listen to during this entire presentation. So initially when I came here, I thought that whether I'll understand any of this, but I could easily find out that there are certain, very interesting links that people are talking about when it comes to machine learning and artificial intelligence in the area of gastroenterology, which can come in the very regular domain of machine learning. So, for example, the idea that we are talking about the data and the having, quality data, and more importantly that whether you can use proper supervised learning, or you can actually use techniques where you can label them data proper using right features. So those areas are basically not very different from the topic that we work on. So essentially, while the language that we speak is different, but the topic that we are talking about, the underlying theme is very similar. So many of these techniques that I think I found that in two presentations was talked about, like detection of lesions, or figuring out the actual differentiation between when the cells become cancerous, the figuring out the demarcation boundaries. These things actually can be easily mapped into a very good deep learning or supervised machine learning techniques. So in that way, I first feel that this is a great domain where I think the engineering or the technical expertise of the academia can actually help quite well, because you don't have to really learn, or you don't have to be actually doctored, but what you finally look at objectively the data which a medical practitioner can provide you, without any issues. And you don't, unlike many of us, you don't have dearth of data, because you are actually the people who are taking care of the patients, and you are actually doing these imageries every day So in principle, if you really want, one can actually really have very nice, academia plus medicinal collaborations that can actually help, in many ways to intensify or improve or even augment many of the techniques that is being developed. For example, the imageries that you are talking about, you are using something called convolutional neural network, which is a very common technique. For example, you are using the different color palette that you are talking about. These are basically image processing. You are looking at pixels data, which comes very naturally to any convolutional neural network techniques, which I think the doctor just few minutes before was talking about. So these are the area which are quite natural to any machine learner or enthusiast or artificial intelligence persons. So in person, if there is a cooperative, coexistence of both the particular domain expert, I personally think that this particular area can only improve, and it will never replace actual medical practitioner, because you need at the end of the data. All you can do is that you can make use of the data in a much more refined manner. So that is where I think this kind of collaboration can actually help. So with this, I think I will just like to, thank the convener of this meeting today, and then if you have any particular discussion, we can actually have also off topic. Thank you.
Thank you so much, sir. I was actually initially skeptical whether these discussions will be of any use for us, or for it might be boring actually for you from the medical perspective. But finally I understood that without inputs from people like you, we will not be able to progress further. So the next few discussions which I am going to talk about, please excuse me if they are novice, if they are irrational, because these are just random thoughts which came to my mind, and I thought that I should put it in this board so that experts like you can comment about. So this is what I thought about. We have so many case scenarios in our general GI practice. One is an IBD patient, clinically the patient is showing a very active disease, having so many loose stools and blood, but you go back and see endoscopically it's very, very mild to moderate. So that's where the confusion and the dilemma starts. You have an active disease, you have endoscopic active disease, we all know what to do. But suppose the scenarios don't match. Can AI actually help in creating an algorithm for such patients? ERCP, we know traditionally we do ERCPs, our successes are good if you are experienced, otherwise it takes some amount of time to gain that. Now, can this AI give a 3D reconstruct image to help us? So I'll just share those images. We have a pancreatic head mass. There are AI algorithms to say whether the mass is malignant or neoplastic. There are few softwares which are in, I would say, in the research, which will be available in a couple of years next. But can a navigation system be there where they can guide my endoscope that you are tilting 30 degrees away, you have to do another 30 degrees tilt to actually get the lesion into focus. So that's where, see, an experienced endocrinologist will directly go and put the scope there and say that, oh, this is the lesion. Whereas a novice person who is under training will require at least 10 to 15 minutes to reach that area. So can we bridge that gap with the help of navigation software? These are my simple basic questions. So to start it with, sir, Dr. Dobashi, sir, the present scenario of endoscopic reporting is we capture the images and we type the software. This is how it happens in India. And after completion, we either type or dictate and annotate the images and print it. Now, can we see in the near future that there will be an AI software which will directly give the report in a comprehensive, complete way? That is, once I do the procedure, will it be able to give a complete report including all the images? Now, what I see is, the advantage which I see with this particular thing is, it is very comprehensive, it will give a very good language, and the terminology will be very good, because I might write it as gastritis, somebody else might write it as gastropathy, so somebody might write it as erosion, somebody might write it as an ulcer. So the standardization of terminology will be better with AI, this is what I feel. And overall good acceptance will be there. And most important is that it will give me the completion report, whether I have done the proper examination or not. That is, my colonoscopy withdrawal time was appropriate or not, and whether all the areas have been mapped properly or not. So by the time I complete my endoscopy and I pull it out, the AI should be able to generate a complete report, including the annotation of the image. So do you see that this is possible in the near future, and your comments on that?
Yeah, I think it's possible in the near future, but finally, the doctor will make a decision about the report is correct or not. So the final decision should be done by the doctors. But if anything, by the way, we can endoscopy can save the time with the CSAPO system.
Yes.
So just to add to your point, I think there are this program called CAD-GPT, which is basically a transformer-based model, which is used now by everyone to generate text, right? And I think many of us has used. So one thing that many of these programs, which is generally prepared report, when you just tell them that this is my prompt, you prepare it. Many times you get report, but one thing that AI is very good at is something called hallucination. So what it does is that it generates things which you are not really actually thinking. So they are not. It's not dreaming. It's basically generating fake reports, and that's because this is called hallucinations, which is very typical problem of any AI. And in these kind of cases, as Dr. Dobashi is pointing, if you actually have a human supervision at the end of the day, that might actually help out extensively in this kind of situation, because you don't really give out a report to your patient which is completely written by an AI software, but it is not at least checked out by a particular medical practitioner who at least understand this report. But at the same time, at the point is the data. If you don't have enough data, the machine will not learn properly. And it will if you have better data, it will automatically correct itself and it will give much better result. Thank you.
Yes, sir. Yes, sir. Sir, we'll take one comment there.
There are some programs available now. When a technician or doctor is doing the procedure, he keep on speaking. I'm going through rectum, sigmoid, and it keep on typing at the same time. So by the time you're done, and you also say, mark this picture, mark this picture. So those pictures are selected out of 10 you have taken. So by the time you're done, report is ready, and it is of your taste and what you're looking for. Because computer-generated reports say a lot of things which are not required.
Yes, sir. True, sir. Sir,
yeah, I agree with what you have, because voice-directed actions by computer systems is now it is very much possible. So voice-directed action is very much possible. So and also from speech or voice to text. That is also very much, it's very much there, because nowadays you have all the voice-based assistants like Alexa or OK Google and things like that. So that whatever that is Doctor has said is absolutely possible. What I wish to bring out to everybody's notice here is that now there is something which is called as explainable AI. Okay, that's very picking up a lot in the research. It's not there like where it will actually be able to say that, okay, why did this happen or why did that happen, and give it an explanation which is acceptable to perhaps a layman or maybe even uphold it in a court of law. But the research is trying to give some it's that you come up with machine learning and classification based approaches which try to give an explanation for the reasons why a classifier, machine learning works with classification. So why a classifier has arrived at a certain decision. Okay, so that's the work on explainable AI. There is a huge lot of work to be done there. Okay, so but as we are looking prospectively, so it would be possible perhaps to make those kind of reports.
So, thank you, sir. Chalpati.
One aspect of endoscopic reporting is also to compare with the previous reports. So, do you foresee that once we get a report on like December 14, 2024, and compare it with whether the lesion has come down, whether it is, for example, a cancer or a colitis, right? So, I'm sure it is progressing, definitely. Is AI really progressing to compare with the previous report probably happened in 2 years back or 6 months back with some kind of treatment, whether and also whether to exactly locate, for example, if we have resected a polyp, that is one aspect of whether to compare with colitis or any kind of inflammatory lesion, and give a report like what CT scan gives, like there is an interval reduction with chemotherapy or with some kind of therapy that the lesion has come down or whether the lesion has increased. So whether AI is progressing in that way. Similarly, whether the recurrence of any polyp after a resection, whether it is ESD or EMR, whether it has recurred in the same location or adjacent location, something like that. I mean, that's good to incorporate in these kind of reports, coming to this particular aspect. And the second and the third aspect is, there is always an aspect of inter-observer agreeability between two humans, right? So, is it always that the inter-observer agreeability is always between two humans? Can it be between a machine and a human? Is it always mandatory for us? Obviously, it's not always mandatory for us to agree whatever machine gives. But what is the kind of inter-observer agreeability between a machine and a human in these kind of reportings? And the other aspect is there any quantitative thing like the completion of adequacy? Like, for example, machine warns if adequate images are not taken. Or does it give any quantitative information like only 90% of, the study is completed, or 10% is still remaining, or something like that?
I'll just add to the first part of the question. Comparison between two reports, possibly that is possible if we have a registry. And if we have something like UK NHS, where all the data is there stored in the same server, and every healthcare professional probably has got access if the patient permits. So I think if that sort of registry and central database is available, possibly AI will be able to easily compare between the old and the present reports. And the second half of it, adequacy testing and all, sir, do you want to add anything to that? Adequacy of the procedure, like whether we have completed the procedure properly or not. Can AI predict that and give us?
So now just AI was started to the clinical setting. So now we are focused on the diagnosis or detection of the lesion. Now next step is as you say, the time, the information with something like a progression or a lesion is the next step to next focus to the usage of the AI system. So I think it's a good idea to improve the AI system for the clinical setting. So I think it's a good idea.
Thank you, sir. We have Dr. Sambit, our medical director, who has joined us. Sir, welcome. Welcome to this GIA Academy. Thank you, sir. Dr. Vadva, sir. So I'll move on to the second question. IBD. So isn't our clinical experience good enough to manage an IBD patient? Possibly, yes, if you are an experienced senior professor or a consultant. But for budding practitioners like us, I think the clinical expertise might not be 100% sufficient. We will need expert comments on that. So inflammatory bowel disease, right from the time I started observing it, I have never seen that 1 + 1 is not equal to 2 in that situation. So I wanted to have some comments from the experts. Can we have an AI IBD tool? So why do we need this AI IBD tool is because I would like to have some treatment guidance. My clinical and the lab parameters are not hand in hand. They are in dyssynchrony. So can I have them in assisting the guidance? Can it predict the treatment side effects? Can it break through? What we have right now is we have a lot of data. So how do we have this data? Some of it is compiled, some of it is not compiled, some of it is with IBD experts. Like there are some professors like Dr. Ajit Sood, who has got a lot of big registry for the IBD patients. So can we have all these data compiled in a fixed format, and can we use this machine learning to have a predictive AI tool for IBD? And what do we want to generate? We want to generate a treatment algorithm. And what do we want to predict? We want to predict the final outcome of this patient, response to therapy, side effects, and we want to also predict an early response to therapy or an early side effects. What was, sir, your sir? Yes, sir. Yes, sir. In the meanwhile, sir, your comments.
Okay, while not knowing anything about the disease or clinical aspects, ab initio what I could say or what I could see is that whenever we see something where the data is there and then we are having uncertain outcomes, all right, so then we have to look at that what is the entire for one particular case, what all are the data points which have been captured. Okay, in the mathematical terms and all, we call it as a very high dimensionality situation. Okay, and so in the classification of very high dimensionality situations is very difficult, and analysis of the data will help to extract the hidden correlations. So if there are hidden correlations which we will be able to find out, and that will give you a more insight as to that in which particular case what is going to happen. So I feel that whichever data which you have, if you are able to analyze and find some hidden correlations, like yesterday to prepare myself for this talk, I was talking to a very close school friend of mine, and he is a doctor. He mentioned that with IBD cases there is something like a kind of a the personality of the patient who are very sensitive, and their mind is really very they are very irritable, or you can say very highly sensitive, maybe because they are hypersensitive, they feel hurt a bit more, and things like that. So I don't know whether that is actually true, but if such types of data points are added into the case histories and things like that, and we analyze it through big data analysis, we might be able to come up with what are the hidden correlations, and then we might be able to everything may be one big label called as the IBD, but within that, if you are able to make different sub cases, and then we analyze each sub case in a separate way, and then find out what are the important characteristics for those sub cases, and then we come up with some path of action for those. Maybe, and I hope that is the way we could think about it.
Thank you, sir. I think that you're talking about some machine learning, deep learnings, and the data analysis from that. Yes, sir. Sir.
I thought I'll just share the few data which is available in IBD as of now. This is a summation graph of some of the studies which have been published. This includes the various aspects of IBD learning. The first of these studies on pathogenesis, where the genes have been analyzed, more than 16,000 genes. The machine learning predicts correctly that which are the patients having a particular set of genes are more likely at the risk of IBD than those who are not. Then we move on to actual diagnostics. As he was saying, the machine learning models are actually giving the score Mayo 1 and 0 and 1 and 2 and 3, and they can successfully classify this into the patients having Mayo 0 to 1 and 2 and 3 classes of the thing. You have a treatment areas, apart from the pathogenesis, diagnosis, management. You have the treatment areas where a particular type of treatment, what kind of response it is likely to bring in a particular patient, the machine learning model is learning to, and prognostication of a certain subgroup. We need to keep this in mind that these are isolated studies. These are validated in the same unit. We do not, although they have given the training data sets and validation data sets here, but they are in the same unit. We need an external validation with a different data sets, because we may have a 60 kg man and a 39 kg or a 20 kg person. What variations which we find in the clinical features versus the endoscopic features versus the healing of these, we still have a lot more to learn in these aspects. So there is a lot of work to be done, but every area of IBD is being now looked into with artificial intelligence perspective. You had asked me a question. I had another image which I would like to share on the IBD in these circumstances. You had asked me about the presence of inflammation. This is that study which has been published using an endocytoscopy to give a gradation of inflammation, and the active inflammation, as you can see, can differentiate from an inactive inflammation in these situations, or healing. So you get to know with the images. These are image, again, deep learning modules of the images, which gives it. But as far as my reading of these things, I do not have any practical experience about it. The success of these models depends on annotations which you give to these models, as he had said. And unless and until an extremely detailed annotation is given, you cannot expect a correct data output. And that is where the limitations are still, we are learning into that area, that what correct way of putting the data into these machine learning models to get the best output of these things. That's the limitation which we are facing right now. No, I just said that these are individual data sets which have been published by the individual. They have been validated by them. They have not been validated by external data sets. That is, when you bring this data set into a different solution, whether they will perform equally well or not, we still don't have an answer for that. So we have to make up our own data sets and then put our machine learning modules in that manner.
I think so, ma'am. Initially, when we don't have our own data or we don't have our own guidelines, like we have EASL guidelines and ASLD guidelines, now we have INASL guidelines now coming up. So I think Western things still don't hold good for Indian scenario, but that needs to be validated by another study. For example, screening colonoscopy, everybody in the Western side, they start the screening colonoscopy at around 50-55. But in India, we still deny that it's not needed, and it's probably not necessary at this point of time. But again, that needs another validation to say that it is not necessary also. We are denying, saying that we don't see much, but that needs to be validated, and possibly it may be needed. So I think we need to have our own data, and that needs to be analyzed. So moving on to the next, this is something which is very close to my heart. I thank my Mr. Abhishek. He is from the Skia technology. We have, as KIMS hospitals, we have a strategic partnership with Skia. Skia is a Korean-based company which is into VR. So it uses the VR to map the organ or the disease of interest, and it actually superimposes onto the skin, bone, and solid organ vessels. In KIMS, we have done some pilot projects thanks to Dr. Manas from Neurosurgery Department, Dr. Parthasarathi from Surgical Gastro. They had used this for some neuronavigation and for the hernia cases. So what we had done is we are trying to do a pilot project in using this technology to help patients understand about their diseases. We know patient education comes from verbal dissemination of knowledge, and now there are some YouTube videos where we can showcase to the patient that this is the disease. So we wanted to superimpose these images onto the patient and show them that this is how it is there inside your body, or this is the area where your organ is at problem, and we are trying to make them understand so that they have a feel of what exactly and where exactly the disease is. So the patient education is one area where we are actively working on. The second is the pancreatic stone therapy. We all know ESWL is a machine where we use for pancreatic stones, urology stones. So that's based upon fluoroscopic imaging, where the fluoro guided, whether it's a pancreatogram or the fluoro radiodensity calculi, are targeted by the machine. Now we are exploring whether this VR can, with the help of the CT data integrated into it, can superimpose onto the body, onto the skin, exactly where the stone is possibly going to be there, so that the beam can be directed towards it, and this is to enhance the therapy of ESWL. And this is something, the third one is ERCP US navigation. So I'll just show you some videos of the pilot projects which are done in KIMS. So this is a neuro navigation which is going on. These are some pilot projects which are done with Dr. Manas' team. This patient possibly has got a neurological lesion, is being planned to be operated. So that is the depiction of the CT scan onto the patient in a VR format. Now we are able to see the tangential, the sagittal, and the coronal sections, and that's the lesion which is appearing. So possibly why this is important for them is they wanted to map the disease on the external aspect so that they can possibly use their ports to enter. I'm not a neurosurgeon, so I do not know how this much is going to help them, but
this marking was definitely useful to them in predicting the final outcomes, especially because these surgeries are going through some essential structures like the brain, which possibly cannot be compromised. So these are the markings which they are making, probably of the Hussain Hayee and the bony landmarks. So this is with respect to the vascularity. They are able to see it directly there with respect to the vascularity. And I think this is one particular marker which probably that's the target tool which is going to be inserted. They are probably going to see which is the ideal site of entry without damaging the rest of the architecture. I think Abhishek will be able to give a more detailed thing. This is the final output. Okay. So the second thing is this is about the hernia case. I think this is the superimposition. So what they have done is they have taken the CT scan of the patient and integrated it into the the tool which we are going to show, and this is the marking of the abdominal organs. So this is for a hernia case, they are marking the muscles. They are marking the individual muscles length and breadth, the sites where they are. We can actually see them visually also, but possibly these are going to simplify the surgical incision sites, making it less invasive, probably improving the final outcomes. So this is how the markings are done, and this is our OPD pilot which we have done. So initially we will be scanning the whole patient. This is the depiction of the organs, that is the lungs, the liver, then that's the bony cage which we are showing to the patient, that's the heart, this is the kidneys, so that's the liver, that's the GI tract, this is the stomach, that's the liver, and we can actually show different diseases like fatty liver, cirrhosis, HCCs, etc. So this is the bile duct anatomy which we are showing to them, the gallbladder, bile duct and all. So what we thought is showing this on the patient themselves will make the patient as well as the attendants a bit more understanding and informative about that. And based on this, probably the patient understanding of the disease, their interest in their own health possibly improves, and their attachment with healthcare also improves. I'll stop here and I'll ask Mr. Abhishek, you want to share something about this?
Sorry. Good morning, everyone. So I represent Skia. So like Dr. Sreekanth mentioned, we are a Korean-based company, and we are actually an AR-based solution. So it's, as you can see, it's projection here which is happening, which is augmented reality. So the foundation of this entire technology starts off with the CT. So we used CT data, and the AI algorithm creates a 3D model, and it forms all the organ structures based on the CT information. So we create a 3D model based on the CT information, and then Skia's main technology is actually into scanning. So if you, my colleague here, Anand, is holding one device. So this device has an integrated camera system, which is patented by Skia. So it basically shoots millions of harmless lasers and does the entire contour mapping. So it maps every pixel, like you can call it a pixel. With this laser, it connects all the 3D contour data from the human body, and then it creates what is called a digital twin, and it fuses the 3D model onto this 3D contour scan model. So and then it projects like you can see there. So some of the, like we worked with Dr. Manas for the neurosurgical cases, and we were able to basically detect lesions, and the teams there, before Dr. Manas actually operates, we were able to do a lot of patient counseling also, which was a sigh of relief. That's where we thought, and when we shared this idea with Dr. Sreekanth and said how much it's actually helping patients and their stakeholders like family members understand what the procedure is. It really gave us a lot of satisfaction, and that's how the OPD liver project with Dr. Sreekanth came about. So, so basically this technology can also be used in various fields because we are integrating it with tooth tracking, etc. So hernia is also demonstrated there. So we're very grateful to see such innovation happening in this department. Thank you.
So this is the device which actually scans the patient. This is only for scanning the patient, and it's not that an previous existing CT can be imposed onto this patient. It cannot happen like that. It is patient specific. Only that patient CT, if we scan for this patient, then we are able to project it onto the same patient. So, so now this is my question for us. What can this help us? So ERCP, we know it's one of the most enlightened procedure of gastroenterology even till date. No matter US has come, third space has come, but still ERCP is very fascinating for all of us. And the success is multifactorial. Patient factors are there, operator factors more important, the experience, the skill set. If you ask sir, like Dr. Vadva sir and all, their ERCP success rate will be somewhere close to 100%. Whereas if you ask novice people or budding gastroenterologists, their success rate will be only 50%. So there are so many other factors. There are equipment factors. This is essentially because when we are doing ERCP, what happens is we are just trying to do a trial and error basis. We are going to put the guide wire into the bile duct and try and attempt to think that the bile duct is in this particular direction. But in fact, the guide wire, the bile duct may not be in that direction. Then we go by trial and error. We use our own expertise, skills, and then try to maneuver into it. So it's all basically trial and error and imagination. Now, what I would think is, once we are able to have a superimposition of this image as AR and VR onto the human body, can this superimposition be done onto the endoscopic image? So, if we preload the CT or MRI, can we project the bile duct of that particular patient on the endoscopic image so that my guide wire access can go through it easily? This will minimize my time, this will minimize the side effects, and it will actually minimize the gap. That is, an expert and medium expertise patient possibly can perform the procedure in an equal way with good benefit to the patient. Sir, Vadva sir, what do you think? Is this a possibility at all?
Actually, here we are not just using the technology AI. It's a combination of technology. You know, you are putting virtual reality or augmented reality and then combining it into AI to extrapolate that data. Yesterday we had seen that the future of AI, that you can use the color mapping technology to find out the gaps of the area where the papilla is. And then using that color mapping technology, you can define the direction of the common bile duct, thereby having a help in cannulation where the opening is done. Now, how much a VR can do it, I still have no idea. You know, I'll probably need to learn more about the implications of VR and the presence of that. But I do believe with what you have shown us that it can be a potential area where it can be used. You have already, we have a data which can be 3D mapped in the form of MRCP, and that can be used here in the form of a virtual, putting it up onto the patient's body and getting us an idea. Yes, it is very useful. Possibilities are infinite. You know, you can possibly decide whatever you can think. In fact, if you give me a permission, I will ask a quiz question which should be you know, very easy for everybody. I have a small video clip which I would like to show.
Yes, sir. It's working.
Kindly look at this movie and give me an answer as to what this movie is. If anybody can give me the answer, their lunch is sponsored by me. This is blood vessels being cut. You can see the RBCs flowing. The person is entering into the blood vessel and going through the blood vessel. This is being controlled. Of course, this is just a small clip. If you can give me the answer, this is what has been taught decades back. Okay. This movie is movie Inner Space. This was in 1987. This was directed by Joe Dante. Joe Dante was one of the sci-fi movie director, one of its own time, and if it's basically a sci-fi comedy movie. But the concept of it is like this: that you miniaturize a human being, put it into machine which is actually equipped with it. You inject it into the body, and then he takes a control of going into the optic nerve, sitting onto the cornea, putting his own camera, coming into the auditory canal, putting his own auditory equipments, and then controlling the human body functions and delivering antibiotics. Right, this person has the infections of the heart walls, and then delivering the antibiotics directly and using certain laser technology to kill the microorganisms going in when we are going to find it. This was thought somewhere, imagine about 5 or 6 decades back, and we are heading to that direction sooner or later. This is called as fiction to reality or bench to bedside.
Thank you, sir. Sir, any comments from? Want to comment about this? Can this be feasible, sir?
As I already mentioned that first of all the first part that the doctor pointed out is data and the classification, and showing that the environment or the demography matters. I think like what I think he's talking about is the issue of data leakage, which is basically like if you basically have, let us say, one particular data and you have trained a model and you have got a, let us say, machine learning model which can tell you that for this particular patient it will work, but you don't know whether if you have a different demography whether it will work or not. So in this kind of cases, I think as you pointed that if you actually have other data set which you can challenge your models to, then you can at least get a more robustness whether the model is working or not. So that is one aspect. Now the second part which you are talking about is integrating VR with with imaging. So as your collaborator pointed out, this cryo-electron tomography is a very common tool now, at least in looking at, let us say, a biomolecular protein structure of the biomolecule, especially the toxins actually. So these are very common tools. So people develop it very extensively. So MRI images, and in many cases the problem that happens is the inferring the structure which is not present from the experimental data. So in those cases AI can actually help. So in that way, I think if you think about the augmented reality or VR, it will be pretty good in inferring how much is not known by the practitioner, but at the same time, like you have to train it with extensive amount of data which has already been your case studies. If you have those case studies and if you have trained the model, then maybe here for the new set of patient it might work much better. But like in principle, otherwise it might, as I pointed before, it might hallucinate. It might give you completely a wrong answer. So in those cases, if you have since you have this kind of situation because you have no dearth of patient data, so if you can train a VR which can actually understand what is already been trained, it will work very good with the new set of patient that you are trying to bring in actually.
I think the first half of the question is the answer for Umadevi madam's question that whether this is applicable to the Indian scenario. Yes, possibly we have to challenge it with the the model which has been imported from the Western literature and then use it on Indian patients, because this is only just to generate a comment. It's not involving directly the patient care. Possibly it can be done with ease. So again, the same thing with the US. We already have some navigation tools already. So again, the same thing. Whether AI and this VR can probably integrate and help me to say that okay, my scope is at least a couple of inches away, please advance the scope, please tilt my scope, please do the big wheel up, big wheel down. Same thing which my senior colleague will be doing from behind and guiding me when I'm doing the procedures. Can this do it? I think possibly there is a lot scope for all of these in future. We might be able to get prompts like the Google Maps in future. I think we should be heading towards it, and we are very happy to be associated with anyone who will be partnering for developing these sort of projects. We will take permissions from Fuji if they are willing to collaborate, and from Skia Technologies if they are willing to collaborate. We will be happy to develop some project of this kind, so that it will be help something like which I would say as a GI hepatobiliary navigation tool for helping us in performing EUS and ERCPs. So with this, I would like to conclude this roundtable meeting, and before I completely conclude, any comments from the... Yeah.
So to add to what you mentioned, actually, when it comes to our technology, there's no room for hallucination because the data set that we feed in is actually the patient's own CT. And again, what we are doing in the second step is actually scanning contour data through, which is mapping the entire through a 3D scan. The only area where AI is being used is actually to reconstruct. So that is one area, but then we have a team of radiologists who are actually guiding the process. But yeah, I mean, only that part is where the AI is used, but the rest of it is actually quite factual and this thing, because we do have the FDA approval for us.
So I think why this contour scanning is very important is because we keep changing the patient's position. We might put the patient in prone position, we might do it in supine, we might do it in lateral. So we need to have this tool guiding in all the process. So we need to have the whole contour mapped. That is the reason we use this external device. Otherwise we have the CT image where the CT can directly integrate into the Fuji systems or Olympus systems and give us. But when we change the position of the patient, it should be able to guide us. So this is going to help us in doing that contour mapping and then putting the actual things in place. Any comments? Yeah. Chalpati.
The difference between the brain mapping and the abdominal mapping is probably the natural patient breathing movements also, right? Not only the position change, but itself the natural breathing movements itself can give some kind of variations, and the AR or VR, the 3D mapping or the navigation system, the purpose is actually to get very close to reduce the error, right? So how much close will it get in real time after all these integrations with all these variables being considered is subject of matter and investigation.
Yes, that's what we are actually looking at. Yes. Yes.
You can integrate endosono image with the EVR. Another is FNA. In endosono, Fuji gives the FNA track. Yes. We want what I want all of us we need is a pre-cut track. That is I always say to my residents, we need a pre-cut track. That is the easiest and avoid the complications.
Actually, using it in AR, just a VR model, using it in ERCP, just a VR model, doesn't give an answer. This is just an improved version of what we are doing, a 3D mapping of a CT scan in a real life imagery session. What I would expect as a trainee or as a mentor to a trainee is an answer to what kind of difficulties I can experience while I'm doing a procedure. If I'm putting a scope inside, am I going to meet a resistance to passage of my scope into the duodenum? Can I cannulate it, and what are the possible success rates of cannulation? If I do cut, what are the chances that it will bleed or cause a pancreatitis post-procedure? These are the answers which we will be looking for from AI. And that is where the integration, this is an image integration, but the data integration of the variables available, bringing into the combination of this to give a right answer for the therapeutics in this purpose. I don't think we are at that point right now. We need a lot more variables to be put into the machine learning for us to give the answers to this question. Because learning an ERCP is not just understanding the anatomy. The learning is facing the practical difficulties when we actually do the ERs.
Very true, sir. Well said, sir. Chalpati.
Sir, actually, just to add what Dr. Sreekanth was also envisioning here is if we actually developed a tool tracking software that acts like a navigation tool. So it can actually, I mean, we foresee that if it's incorporated in the tip of the scope, while the AR projection of the anatomy is there, as we navigate, you will get to navigate to some degree and extent to important anatomy. And what Dr. Chalpati Rao sir said, a question last time is, yeah, that's a very important question, sir, because in order for that to happen, the patient has to be lying down to take the CT. We need to replicate that similar position for it to actually replicate the VR projection there. And the AR component which is incorporated actually does account for some degree of breathing, but it is going to evolve more. So it does accommodate some degree of breathing. So that's why if you notice, it was auto-correcting in one of the OPD studies there.
So once they map it and locate it, and then when they take it on the table, then these many interviewing organs actually come in, right? So on the second pass, they say, on the second time, they say that it is not possible. The bowel has come in interviewing. So all these things, the regular physiological things, they interfere, and we need to get into that, place so that we actually consider all these variables. That's what I mean.
Yes,
I think with this, sir.
Yeah, so I'll have to add here because every month I think I come across 2 or 3 startups who come and pitch AI to me every month. Even I suppose Abhishek had pitched to me maybe a year back. Okay, so and what is important for us, all of us to understand is we can think of AI using everywhere, but where the AI is going to be successful is because AI as a tool is a great leveler. Chalpati is an excellent operator. There may not be an excellent operator. If the AI helps this operator to bring him at par with Chalpati, only then the AI is going to work. Only then it is going to come to the market, or else it's just going to be an imaginative tool. For same way, everyone has taken example of Dr. Manas, who is a brilliant neurosurgeon. For him, the AI might give him a 5% incremental value. But if there is an AI that gives a 30% jump in quality care for a newbie, only then the AI will work. Because the way we have to imagine AI is it's a leveler. No one is going to have any advantage. And the second thing I've been hearing is data. Now with data, when I come across so many pictures, there is extensive data in healthcare. The problem is we doctors have diluted it by saying that we have put in by saying that medicine is not a science, it's also an art. That is the problem. Because we have made it into a partly an art, the quality of data is never good. Maybe the Western countries, they document everything. So maybe the art is gone in medicine, but here everyone says, why you are a good operator? Because he has that extra component of art in him. And so we are diluting it. So quality of data and level, when we level the things, only then AI is going to be successful. That is what I have learned. Yeah, so that is what I have learned after mingling with hundreds of people.
Thank you, sir. I think at least if we have that small step right now, possibly 20, 30 years down the lane, our younger generations are going to have a big volume of data from ourselves, and this is possibly going to help the future of AI and healthcare in creating a good AI tools which will help us in improving the health of the overall mankind. Thank you all for a wonderful participation. Sir, thank you, sir, for all your inputs from the engineering aspect and from the medical gastro aspect. Thank you all. Now we all break for the live sessions from here, and we will have the live demonstration by our two esteemed faculty. Thank you, sir. Thank you. Sir, 2 minutes. Just 2 minutes. Sir, we'll start the cases. We'll start the cases. Sir, two rooms will be operating. Sir. I'll be joining in 5 minutes.
He will let him do the GI because he is excellent in that.
Yes, sir. Yeah, yes, sir. Sure, sir. Venu. Sir, one this. Yeah, I think the delegate, we will all join in the OT. Sir, this. I'll just join you in 5 minutes, sir.
Explanation of the procedure.
Yeah. I'll just. No, we'll just illustrate these two people. Right. Sir, Ajit, sir. Sir, 2 minutes. We'll felicitate the guests of honor, sir. 2 minutes, sir. Sir, thank you so much for coming, sir. It's a good thing. It's a nice. నేను చూస్తాను సార్ మాట్లాడతాను సార్ యా రైట్ మేడం 2 minutes I'll just sir we'll felicitate our guests. Chaitanya sir, at the outset I would like to thank Professor Atul Negi and Professor Jagannath sir for joining us. Thank you very much for coming at a very short notice. Actually, we had informed them only 5 days or 6 days back, and we asked them to come for this small roundtable meeting. I think most of our discussions were conceptual or maybe hallucinating type or imaginative type, but I thought that unless we think, we cannot create something new. So that's the reason I bought this particular roundtable meeting. Actually, it was not a part of our initial project. It was only about some cases and understanding about this. I wanted to collaborate because we as KIMS, we are very happy to be associated with industries like University of Hyderabad and Tata Institute of Fundamental Research. We want to have research happening at our place, and we would be happy to collaborate with all of you. Thank you, sir, for this kind gesture to join us for this wonderful meeting. Thank you, sir. Sir, please. Ajit, sir, please. Please accept a token of gift from all of us, sir. Atul, sir. It's a small Buddha statue, sir, where we are trying to enlighten ourselves under this giant tree. Thank you, sir. Sambit, sir. Sir, thank you so much, sir. Thank you for joining us and giving us this wonderful. And we will connect back in a couple of weeks individually, sir. We will try to see what new things, as Madam was talking about, usage of ultraviolet or infrared technology in getting a better tissue diagnosis, etc. We'll think and we'll have some more small boardroom discussions about where AI or possibly newer technologies, not leave about AI, newer technologies can help us, which are still not explored or yet to be explored, sir. Thank you. Madam, thank you for a wonderful participation. Please. Momentum. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. We'll get it to your church. Madam, sir, 1 minute. Yes. Please accept this as a token of gift from us, sir. Thank you, ma'am. Thank you for a wonderful participation and sparing your time on a Saturday. Madam, I was also a state student, madam. Thank you, ma'am. Thank you. Thank you, sir. Sir, will join us in that meeting, sir. Sir, thank you, sir. Thank you.
lesion in the stomach or esophagus. So I will start the observing the stomach. First, I will observe the pilus like this. So there is no lesion in this area. AI doesn't detect any lesion. This is the antral side, and AI detects some polyps. To the white light to elevated lesion, but there's no demarcation line. I evaluate this lesion is just a polyp or the elevation of the mucosa. I don't think this is neoplasm. Anyway, the background mucosa, there is no atrophic gastritis. So this patient has a low risk for the gastric cancer. So I observe the whole antrum side and then observe the anal side. So if you want to make a distance between the tip of endoscope on the gastric wall, please push a little bit like this. Stretch the stomach. So you can stretch this. To observe the gastric wall until the whole bunch. The whole bunch. If we have the image cone, it will help to reduce the bubbles. After washing the stomach, I will start observing this. This is a polyp. There is a polyp. Once you make the polyp, please come close to the lesion and make sure to observe the surface of the lesion. So the region has a demarcation line. I think this is the surface pattern is almost regular. So anyway, there are some polyps with the same pattern. So there's I think those multiple polyps is the linear region. This is the observation of the cardia. And please use the up angle and the right angle like this. So the people with endoscope can bend well. So we observe this area. So please make sure the landmark checker give you a sign of the completion of the hernia sign. And then I focusing on the posterior wall. That is, I will rotate the endoscope and make the gastric wall posterior side like vertically like this. So we can observe the well for the posterior side. And then pull back the endoscope and observe the gastric body with the curvature side and anterior side and there's a curvature side. So I think the procedure time is about 5 minutes, so I can observe the whole gastric wall. Like this. So please inflate the air until the hole is finished. So the stomach is well expanded. Like this. So this is the scene of the junction. The AI have not given you a sign of completion of the observation. Junction side is pretty challenging to complete, to accept the observation for AI system. So now the AI give you a sign of completion. Right? So in the polyp in the stomach, I don't think it was a neoplasm. Because the surface pattern is almost regular. But the duodenum is challenging to do the different diagnosis only by endoscopy. So I will take biopsy from the polyp. It's okay? Yes. So anyway, if you detect a lesion like this, we change the modality from the white to the white and make sure the demarcation line and the surface pattern. We have this is not an endoscope for the magnification. So if you have magnification endoscopy, please use the magnification mode to do a precise diagnosis. So I'll take biopsy from the polyps of the duodenum. Use the 2 polyps. So I will take biopsy from the 2 polyps. So I finished observing the duodenum. While it is low in the endoscope, I usually use the white light mode. And put that endoscope slowly with observing the sequence. And in the cervical part in supervis is also challenging to identify lesion. So while withdrawing the endoscope, I always make sure the lesion under the line. It's finished. That's it. Finish. So I have already identified the typical points. So just suppose sometimes there's so many conditions that can be That's it.
Fine screen.
This area is regular. In such scenario, again in ESG becomes the standard care. You have a demarcation line. There is a possibility of invasive malignancy in this area, where a magnifying possibility.
I would if you do that. So the discussion about the AI. Beyond the imagination.
Yes, normally the linear part should be less than the vertical part. This is almost circular. This you will have more of this component than the abhorrent total diameter. Here you will see they are almost equal. So this is more of a polyp than a laterally spreading. Yeah, laterally they are also called as LST. There are two types, granular and non-granular, and there can be an addition of nodules in that. So we divide our therapy based on the presence of what type it is, whether it is granular or non-granular. While granular can simply be done with a EMR, non-granular has to be done with an EAP. A nodule increases the risk of maintenance. So EAP is not a problem. Here it looks very similar, but it is not. Here you have the diameter, which is equal in both the directions if you look carefully.
So lateral is
lateral is pretty good. That's why they are called as a lateral.
So coming to the CAD-EYE, how it will help in this case?
See, CAD-EYE in this case possibly may not help much. CAD-EYE, as I demonstrated, is useful for detecting a smaller characterization of CAD-EYE is, suppose you and me are not expert enough to understand the genetic classification. I don't know whether it is a neoplastic or a hyperplastic tumor. So it will help me to understand that this is an adenomatous polyp or a neoplastic tumor. This needs a resection. When you have a yellow coloration coming, it needs a resection. Very simple answer. So that's a relatively basic level of understanding. But determining the therapy depends on lot many other factors. That's why you will have to have a knowledge of the classification as well as the outcomes. What outcomes you can get with what kind of therapy. Basically, the armamentarium stands from endoscopic therapy to surgery. And endoscopic therapy, you can divide it both into EMR and ESD. And EMR goes into subclassification of what you will need. You also have something called as underwater EMR. Here it will not exist.
If the lesion is slightly larger, would A be a benefit to tell us which suspect area we can target for biopsy to exactly identify if the invasion or
BLI will be able to tell you that because of the vascular alteration. AI will not be. Like in this case, you can see that this is in BLI mode. There is an area which is slightly depressed in this situation. There is a possibility there is a bleeding there or abnormal vasculature. Better differentiation of vasculature is on magnifying endoscopy. This is not a magnifying endoscopy. I'm not trying to classify that. But that will be one area where we will look into for the malignancy.
The problem is we are not seeing.
You might have taken a biopsy earlier?
Possibly, sir.
But this is for the long run. It's possible. That's what I'm saying. You will have to have a vascular structure to identify what it is. This scope does not have. Actually, this button usually with the magnifying scope will be having a magnification result. So, primarily what you look into it is the pitch pattern of the surface and the vascular field is what you have. And also one thing which we need to keep in mind is the amorphous areas. Suppose if you see an amorphous area in between where the vessels are completely absent, with almost destruction of the surface area, that could also be another potential malignancy.
There we have to take biopsy.
Yes.
In endoscopy, there are
I'm not sure. Basically, you will be able to get much better idea about the margins of the tumor with a endoscopy. So where you need to take an incision with endoscopy. Area where there is a malignancy, yes. If there is a pit where you can't clear the dye out, then that could be another area. But that you can assess with the help of BLI. Margin assessment is done very well with that. Margin assessment is better even with LCI. Actually, actually LCI should be able to give you a clear-cut idea about the margins here. If you carefully look at the end, you can see the margins very clearly.
For the marking or the incision, generally I prefer doing it, as you have said, to delineate the borders. I do generally under the contrast industry like NVI or BLI. So that gives better delineation.
Yes, and we take slightly 5 millimeters away from the margins. In these circumstances, circumferentially mark it. If it's a larger lesion, we create a pocket. If it's a smaller lesion, you go ahead and do that. If it's a small, this lesion, you can take an incision circumferentially and then go through it. If it would have been a larger lesion, then you put the oral end first, then the oral end, and go in the circumferential.
Giving the output size or something. If it doesn't, if you do an extra CAD is trying to focus here.
No, CAD is focus.
Characterization is always BLI.
He's checking with the neoplastic or not.
No, CAD is giving it that. Gives you that one. This is the. You have to use detection mode is LCI, which was the previous one, and the characterization mode is BLI. This is what you will achieve out of it. This will be more useful to a person who is beginning and searching for the polyps which are less than 10 millimeters. I clearly said there is no benefit of AI when you are looking at 10 millimeter or larger sizes. Majority of the time you will be able to identify some flat polyps, that is type 2B kind of a thing, can be better appreciated with the BLI than with LCI and BLI.
So the virtual scale that you have shown, is it in practice or is it?
Yeah, it is in practice. It's in Europe. It is there. I think they are putting it in Indian drugs.
So the circle varies with the distance of
the circle comes at a fixed level, 5 millimeter, 10 millimeter. So when you put it in, the circle comes, so you know where exactly it is. You have a vertical scale also, so you know how much is that. So suppose if we have this, we put it at this corner, then take it to that corner, you will know it is 20 millimeters or 22 millimeters.
You need to move that circle.
No, not. You just need to stand there with the laser pointing to at one end. When you fix a point, from where you need to measure, then the circle will come. You fix up, you first activate a laser to put it at one point, and then the circle will come. And based on the circle diameter, you get to know what the exact is. Yeah, sure. Gravity is really the best helper for us. So you should always put the lesion above and the gravity below so that the lesion falls down.
You can even start working in a dollar block also. It's all about the gravity.
No, you can work anywhere, but you should always put it in such a way. There are two things. If you are putting a lot of fluid, if you put a gravity down, like you put a lesion down and facing the gravity, you will have all the fluid accumulated in there. When you put the lesion on the opposite side, Here, ESD in this situation, it will be worthwhile. The easiest way to how I do is I put in a water there and we'll see where the water is going and take at the opposite end, bring the lesion to the opposite end and then cut. It doesn't matter whether it is 6 o'clock, 3 o'clock, 4 o'clock, it doesn't matter. What matters is the gravity and
Just like what we correct the root from the posterior or anterior. Patient is in that just put some water and see
where the gravity is. The gravity helps. For example, now you will see that that's the dependent portion. Okay. So this portion, if you bring it down like this lesion and put it in that area, you are going to have a difficulty. What you need to do is to choose the opposite wall and then cut it. Understood? So that you have the clarity of vision, number one, and number two, you have the assistance of a gravity when the lesion forms. I have one ESD in my thing where where you can understand the assistance of gravity in that situation, where the whole lesion actually just flips on its own. You don't have to do anything. It gives you the path where to cut once you have cut the whole area. In pocket creation method, it is not as important as, at least in the beginning, when you create a pocket. But in a non-pocket creating method, gravity is very helpful.
We'll move on to the next place.
Neuroendocrine, NETs, submucosal lesions.
Yes.
It's part of that.
Most of the lesions are coming from the urinary gland hyperplasia. Without the image form challenging to remove the old bubble. Sometimes I observe the lesion under the water, like this.
We using Japan Smithicon
Yes, yes, I use, every time I use the image comp to reduce the bubbles. I highly recommend you to use our image comp because the precise intervention is mandatory.
How much you use that? How much time before the
I can find the point distribution here. However, under the view line, there is no demarcation line. This is something like actually this is not a lesion. Some doctors say there is irregular microdistance, but this is the pattern for the before I know the true name of that, but this is not a nephros lesion.
అది కూడా చూసుకోలేదు కదా ఎంతో మంచిగా नीचे ठीक कर लो सर करना
दोनों फोल्ड के
सेंचुरी हॉस्पिटल
then ఎందుకు పట్టుకుంటున్నాను టైప్ చేసిన కూడా we can start the arrangement of that సార్ వచ్చేసారు ఇంకా Charner is a good place. What time is that? Your flight is in the morning. Early morning. Charging on time? ఏది
ఇదా ఒక పాయింట్ ఉంది బ్లింక్ అది
ఆన్ చేస్తుందా వస్తుందా
Only thing I had to do right admission is study. So that's the only thing extra. Otherwise, I think more counseling and writing admission extra.
ఏంటి
కుర్చీ అటే
మాయిటర్ తీసుకురా అదే పక్కనే జరుగు అడ్డం మాయిటర్ ఏదో సార్ ఆ మాయిటర్
పైన
అడ్డం రెస్పాన్స్ సరే
ఓకేనా మానిటర్ Sir.
Right here. ఎందుకు అట్లా పెడుతున్నావు ఫ్యాన్ మంచి పెట్టు హైట్ లేపుకో ఏముంటుంది కదా ఎందుకు ఎందుకు పడుతుంది పట్టుకో ఫ్యాన్ పట్టుకో
AI has very little role directly to be very frank with you, because it's a very visible growth. However, we can, since it's a polypoid growth, we can look into the characterization of this particular growth, looking into the mucosa and try to understand what we are actually looking at. So there is a feature that you can see is the spontaneous bleeding. This presence of spontaneous bleeding is indicative of an underlying disease. These are tribal vessels which usually bleed here. What we will do is we'll try to look at the surface pattern of it and the vascular pattern in between. In LCI here, we will look at the edges, whether they are there or not. Then we'll convert it into PLR. Indicative of pregnancy, we are not seeing a tumor at the moment. we'll just focus on this because the more I'm trying to clean up, the more trauma and more the loss of features we have. We'll go into the BLI mode. We know that this is a malignancy, there's no doubt about that. Now whether there's what kind of classification we look at it, we'll try to describe that. And the surface pattern here, if we take it, obviously looks irregular. It is not uniform everywhere. There are patches of areas where you have a tubular patches. You have a dilated irregular vessel. Now, can I have the cap? We try to do. BLI mode is what we will use for vessel characterization. Just to see that there are multiple spots of vessels, but there is no regular pattern of it. Can you see this here? Now, if you look at it, there are loops, there are linear vessels, there are irregular dilatation of vessels. So this is definitely what we call it as Janus type 3, and it is an obviously evident malignancy here. This can be kept with a higher confidence, with very high confidence that you can be very sure. You can look at the different areas to see which can show you the one characteristic which I already told you is the spontaneous bleeding. Now another area, here the surface pattern looks regular, but vascular pattern is still irregular. You can see a large dilated vessel in between, and that is again a feature of malignancy. So, irregular surface pattern, irregular vascular pattern, dilated areas, and if we carefully look, there might be some amorphous areas also for us to give an idea about the malignancy. Of course, you people can say that it's very clearly evident that it is malignancy, we don't need it. But yes, a smaller polyp on the similar dimensions will help us to understand these features. So primarily we are looking at the features to understand what we will be looking at. That's when we are looking at the polyp which exists. As I said, AI is not of much benefit here. You don't need AI to diagnose this as a polyp. You really don't need. But in the previous copy we saw that the actual benefit of AI is diagnosing a small polyp. BLI and LCI, here you can again see that. You can see the vascular areas which are grossly dilated vessel here with irregularity. So this is what I think I can show you this one. Of course, this patient obviously will go for surgery. It's an invasive cancer. Any questions? No, it is an invasive cancer. This is an invasive cancer where you cannot think of anything except surgery. ESD with the previous one, the first one which we took, that is ESD. You could see that virtually everything is irregular. There's a deep invasion in this. This is going to be, I have a feeling if you look at it, it is beyond muscular dystrophy. Actually, such an
advanced cases, there is no significant benefit of these technologies. You have a very obvious, very evident.
In this context, I would like to remember one famous statement which my teacher always used to say, what your brain does not know, your eyes will never see. So possibly, if you think that you might pick up and then you actually look for it, you might pick up these lesions in our scenario also. Of course, the incidence might not be that great as in Japan, but definitely some early lesions might be picked up with your help of your techniques. Thank you, sir. What was it?
I can only say I enjoyed my day. Thank you for inviting me, number one. As a convener of this group, I wish to thank Professor Dobashi taking enormous efforts to come, have a quick trip here and then going back. It was certainly a lot of effort on his part. I can see the stress of making this workshop successful on his face in the morning. Although he's smiling now, that's a good part of it. So I hope whatever efforts you have put in has borne the fruit of the day. We need support, and Fujifilm has been steadfast in bringing this academy to the forefront. I cannot say enough thanks to Dr. Reddy's laboratory, because they may not be visible, but they have worked behind the scenes quite a lot. I have troubled Rakin for writing an email, send me the feedback so that we can modify the program. And just because I am praising you, are not going to getting away with it. You are continuing to get those things back. So, but I am still thankful to all of you, the entire team, the way you have carried through. This program would not have been this program had all of you not participated the way you have participated. So all thanks to you that you have time off come, and I hope you enjoyed your day here. I can only say that we are at the beginning of AI revolution, and this is going to become bigger, better. We all are going to be a part of it. It is up to us to take this technology near to our heart and then use it to the best for our patients. That's all. Thank you so much.
Thank you, sir. Thanks a lot. Monica, you have some.
Please scan the code and let us have your honest feedback, so that in the next course we are able to incorporate those feedback, and definitely the entire steering committee of Gastro-AI Academy is really willing to have the positive feedbacks and the negative feedback, all kind of feedbacks coming in after each program. So please take out 1 minute of yours and let's have your feedback. Thank you.
During this time, the feedbacks are being given. I would like to thank the Gastro-AI Academy for giving us the opportunity to host this meeting and to disseminate the knowledge of artificial intelligence. A very special thanks to Dr. Vadva and Dr. Akira Dobashi for spending a whole day with us and helping us understanding and learning AI. I would also like to thank the Reddy Laboratories, Fujifilm, who had been constantly engaging with us to get this program into this mode and making it a grand success. Thank you all. I'd also like to thank our team at KIMS Hospital, the operations team, the anesthesia team, the nurses, the technicians, and the paramedical staff for extending their support and making this program a great success. I would say that our travels department and our branding department had been on their toes for the last 2 days to get all these things in shape, and a very special thanks to them for doing many things in the last moment. We didn't want anything to be spread in a wrong way, so we wanted everything to be perfect. So they helped us a lot. A very special thanks to all of them, and my staff who had been working relentlessly for the last 24 hours to make sure this program has been a great success. We intend to continue these sort of programs in association with Fuji and Dr. Dobashi. In future, we'll be troubling you and calling you again for teaching us in detail about the AI, about BLI, LCI, and that's one area which is very close to me. That this optical endomicroscopy, BLI, LCI, and NBI, I would want knowledge of your level to be disseminated to our young budding practitioners. So if the survey is done, I think so.
So I hope can we just change now? I hope everybody, all of you could scan it and there's no issue with the link or something.
So we'll have the last part of the session, that is the certificate distribution. I would like to invite Dr. Akira Dobashi and Dr. Vadva sir to distribute the certificates.
I mean, anything's okay.
Dr. Bhargav, please. Dr. Srinivas, MG. Dr. Chelapati Rao. Dr. Sridhar C.D. Dr. Sridhar. Dr. Anurag Sachin. Dr. Samad Abdul. Dr. Samad Abdul. Dr. Harneet Singh. Dr. Srujan Kumar Dashyam. Dr. Venkatesh Kabisetti. Dr. Ritvik. Dr. Harsh Kapoor.
Please join us for a group.
Because we need to write.
have just one last case of colorectal. If you're interested, you can stay back. That's, you can take it next.